are also trying to add and strengthen is a multi-sectoral coordinating committee. We have worked hard on the tobacco control. A lot of our policies are in place, and a lot of stakeholder engagements are also in place. Looking at the service delivery now, we have improved a lot as a country. If you look at those are our maps, those two Eswatini maps. The first one is showing a sparsely distributed facilities that were providing services for NCDs. And then the last one on the right is now showing a more concentrated distribution, which means we have actually decentralized from hospitals and health centers into even clinics with our NCD healthcare services. And we are so grateful because we think we are now reaching out to more people in the communities. We have also established an NCD hospital, which is just going to focus on the cancers, as well as the other essential services of NCDs, being mainly the cardiovascular conditions. This we did after we repurposed a hospital that was meant to be a TB hospital. And because the wave of the TB epidemic has come down, it was then repurposed into an NCD hospital. We are also looking into establishing a radiotherapy facility in that unit in the future. There is also a fully decentralized and integrated NCD services into the primary healthcare, as you can see on the maps. We are also developing an integrated chronic disease management framework to inform service delivery for NCD comorbidities. We are building capacity on our healthcare workers. The different cadres are having continuous training to make sure that they are able to handle the different types of NCDs. And we are also making sure that we have annual quantification and forecasting for NCD medicines and commodities so that we don't run out of the stocks that we need for our medicines and supplies. This is now still at a service delivery level. We have all the guiding documents in place. Our standard treatment guideline and essential medicines list has just been revised to include more of the NCD conditions. And also the guidelines at primary and tertiary level facilities are available and are in use. We have the protocols and the SOPs. And also we have included some NCD chapters on the HIV and TB guidelines to facilitate an integrated management. On the cancer prevention and management, last year in 2023, we introduced the HPV vaccination program countrywide, targeting girls 9 to 14 years. And we are currently working on actually extending that to the boy child as well. But we are happy with the introduction of this program because we are seeing a lot of girls being vaccinated against the human papilloma virus, which is actually very much related as a cause of cervical cancer. Early diagnosis, we have improved on the screening and early treatment of cervical lesions in clinics. We have also improved on screening of breast and prostate cancers. We are also working on the treatment and palliative. On the injury and injury prevention and control, we also consider the road traffic accidents as NCD conditions. So we have developed most of our policies and they are in place. And what we are also riding upon is our EMS ambulance system, which is also working very well. With a toll-free line of 977. And this is for the whole country. And we believe that it is going to assist as we respond to most of our NCDs. Awareness and education still remains a strategy that we employ as a country. We do a lot of mass media communication and health education. We also do much of commemoration of key health days, be it the World Kidney Day, be it the tobacco day, be it the mental health day. And those days, we actually aim for improving the awareness in our public. And we also
Dr.
do a lot of...
It should be concluding.
Okay, thank you, Sam. Yes, so I think I'm left with 1 or 2 slides. So partnerships are also very key and important for Eswatini. We believe in working with our development partners, as you can see, implementing partners as well. And also we include the civil society for advocacy and also for strengthening some of our interventions. Research is also not left out. I did mention earlier that we are doing our STEP survey this year to see the prevalence of NCDs in the country. We have challenges. This is now my last slide. We still have challenges, which is limited healthcare, resources, limited awareness, unhealthy lifestyles are still persisting, limited data and surveillance, absence of multi-sectoral coordination committee, and we are working hard to put all that in place. Colleagues, ladies and gentlemen, we believe that if we elevate our response on NCDs to the level of the Prime Minister, like we did with the HIV, we believe that we will be more successful. And that is what we are aiming for, because we believe in the multi-sectoral and whole of government approach in controlling our NCDs. Thank you.
Thank you. Let's appreciate Doctor for that. These are rich presentations, but they really need extra time. We are going to dive to our second presentation by Dr. Viraj Rampasi. But as he comes, I would really want that you document the promising practices and lessons so that we can make a collective practical solutions, which will be presented to the ministers of health for their directive for implementations. So let's be able to capture those.
Very good morning to all of you. I'm Dr. Prithviraj Rampati, Director of Health Services from the Ministry of Health. I've got my 2 colleagues also participating here, Dr. Mohamed Fawzi and Dr. Debi. I wish to express my sincere thanks to convey the message from the Ministry Health Minister on our invitation for this session. I take the opportunity also to congratulate the EXA committee management for the 50th anniversary on this issue. Let me go up with my presentation. 3 main topics: communicable disease, mental health, and substance abuse. Yep. Can you move the slide, please? Okay, so first slide, we missed 1 slide. The first one. Okay, so first slide, please. First slide. Okay, so Mauritius is a small island state in the Indian Ocean. Next, please. Okay. Okay, we have a very small country with 1.2 million population. We are a middle-income country with a diversified economy. Our life expectancy is 75 years, often male 75 and female 78. Our population, public service occupies 70% of the population, and 30% of the population goes to the private sector. We have a male to female ratio almost 1-to-1. Say state-funded healthcare services. The funding is for this year, budget year 2024 was 17.2 billion from the government sector, and out of pocket was almost the same. With our demographic change, there are 2 demographic major changes which is happening in Mauritius. The declining birth rate below sub-replacement levels, and we have an aging population above 60 years, amounting to 20% as of today, and expected to reach 32% in the next 25 years. Next slide, please. Okay, our health system constitutes of 5 regional hospitals, 6 specialized hospitals, and 148 primary healthcare centers. Our primary healthcare centers have got 3 layers, 10 mediclinics, area health centers, and community health centers. Okay, so let me go to NCD experience. Mauritius conducted 7 NCD surveys in last 37 years. Every 5 years, we have an NCD survey. The last was in 1921, and at present, we're implementing the present National Action Plan. A special emphasis has been put in this new action plan on mental illness, cancer, and drug addiction, substance abuse. Okay, so just to give you what is our latest statistic on NCD diseases, diabetes is 20%, hypertension 27%, obesity and overweight is 72%, childhood obesity is on the rise, smoking and alcohol is still taking a very high percentage of our burden, and then we have cancer on the rise, psychiatric illness and drug addiction is taking a very high toll. The mortality for Mauritius is cardiovascular disease 33%, diabetes 23%, and cancer around 22%. All our services are competing with a new trend which is coming up, infectious disease burden, HIV, dengue, and leptospirosis are 3 competing diseases with NCD where we have to manage. Okay, this is the trend of diabetes prevalence over the last 37 years, and you can see initially we had a growth, and subsequently now we're stabilizing due to our intervention taken over the last 37 years. We can't say that the prevalence has gone down actually, though there seems to be a slight decrease, but we feel because of the rising incidence of obesity, the chances that we'll maintain this trend further ahead. Hypertension, 27%. Again, we have the same problem over the years. We are reaching around 30% of the population, and it is being managed. Overweight and obesity, as you see, we are on the high rise, and recent survey showed it was 72% pre-obese and obese patient. And that's a really challenging scenario, obesity being the mother disease across for all NCD diseases. So we have to manage obesity as a top priority, and that's what's the new trend of new action that we're planning to take. Okay, alcohol consumption is very high in Mauritius, and the trend is still higher recently. Okay, physical activity, luckily we have been able to manage NCDs through increased engagement of the population on physical activities, and we have built up quite a number of gyms, tracks, and so many activities taken at the school levels in the school scenario for new candidates. Okay, so our NCD services we can break down easily into 2 parts. Prior to 2022, where internal medicine physicians were responsible for the care and community physician in the primary care. As from last 2 years, we have changed strategy, and most of our stable chronic cases of NCD patients are being decentralized to the primary care. And they are being followed by not only the community physician, but the specialists are going down the primary care, especially in the Mediclinic and AHCs. And essentially the endocrinologists, the internal medicine, cardiologists, and community physicians are taking care of these people at the grassroots level. Okay, so recently, only this year, we have planned to enhance our services at grassroots level by rebranding our NCD services into a NCD lifestyle and wellness clinic in Mediclinics. The whole idea behind the process is because we have been here for 37 years with NCD action plans and so many things, and not much, we have achieved something, but not really to what we expect. And hence, because obesity, we feel is the mother disease for all NCDs, so this is where we're trying to focus by restyling our NCD services. Lifestyle and wellness, the word has been used to sort of hide the obesity taboo that stays around management of obesity. So we have changed this to lifestyle and wellness clinic. The concept is to provide a one-stop shop comprehensive NCD services, all in one place, one block, and one go concept. One go concept means when the patient come in, so all from the screening to the nutritionist to the diagnosis to the all the food care, retinal care, everything go in one process. Of course, if we're just starting it, we are at the very teething phase, and hopefully we will be implementing it successfully in the next few months. So this is the services that we're putting in place. So this is what it looked like, basically. So we have all the setting in one clinic where all the specialties are there. Obviously, specialties, they are not there every day, but they come in session, but it's still the services available there. So they are screened, followed up by the community physician, and then we have all the obesity clinic, smoking cessation clinic, and recently we have introduced exercise referral prescription for some very obese patients. Then we have the foot care, the retinal screening services, and the laser therapy is also available in the primary setting. Now we are establishing the rehabilitation services in the Mediclinic, especially so because we have been having a lot of stroke patients, and rehabilitation at grassroots level makes sense out of it. And when you said wellness, illness, complementary medicine, I believe the yoga concept is something new and which we're planning to introduce in Mauritius. So probably when we talk of mental illnesses, stress management and other issues related to behavioral changes, mental scenarios, so probably this is one way of solving the issue. Okay, so coming to the psychiatric mental part of it, we are presently working with a mental health amendment which was presented in 2021, where the patient right has been maintained in the process. Previously, it was a Lunacy Act in 1998, which was repealed. So we have two phases here. Before 1997, it was a very centralized service. It was managed at only one tertiary regional hospital. It was initially called Mental Health Care Center. But because of the taboo around mental services, we had to change this to a new name, and that is called a Brown-Sequard Mental Health Care Center rather than hospital. Yeah, so just change the name. Okay, and this is what's happening. So it was in 2022, we decentralized from the tertiary level to the regional hospital. In all the 5 regional hospitals, we have psychiatric services now. And further down the line, as from January, recently, we are going further down the line to the primary care. So we have developed community psychiatric services where the patients are taken care of. And obviously, as we see, the prevalence of psychiatric illnesses are on the rise. So that's where we're getting down. The hospitals are getting congested, and we're moving down the line. So these are some of the psychiatric services that we're providing. Inpatient services, addictology services, psychological services, medical social services, community psychiatry, occupational therapy, electroencephalography, ECT, and recently we have introduced a magnetic resonance therapy for psychiatric illnesses. And then we have the Life Plus unit, where we have a hotline for suicide prevention. And we have a special hotline to manage some of these patients online. Okay, so new psychiatric services that have been introduced recently are child psychiatric services. We have around 3 autism centers where a patient come for daycare services. We have addictology services. Residential care home project is something recently because we have too many patients who are in stay in the chronic hospital, chronic care wards. So we are sending these patients in the residential home outside the main hospital. Okay, we have developed the early dementia clinic, and we are also providing our services in the prison. Okay, we have also introduced a latest drug for management of psychiatric illnesses. There are 3 drugs we have introduced. As I said, transmagnetic stimulation therapy has also been introduced recently. Okay, staffing, there's lots of staffing training going on to cope up with the increasing volume of psychiatric illnesses. Okay, so our action plan, HSSP 2024, is coming to an end, and we're working on a new strategy, specifically standalone for national mental illnesses. And we are having a plan for autism being put in place. Okay, that's the end for it. I think we have changed the slide there, but we have also talked about substance abuse, which is not included there, but a lot of work is being done there. So we can thank you very much.
Big appreciation for Mauritius. You will just keep your comments. We're going to receive all the 5 presentations, and then we shall be able to have the discussions. So I will request my colleague to take us through. Just call the other next presenters. Then later I'll also lead the panel discussion.
Thank you very much, Chair. Let me call Dr. Mole Naisanga to give a presentation on advancing collaboration for mental health in the African region. This is a partnership approach to landscaping community-based mental health interventions, policies, and actions. Thank you.
All protocol observed. Good morning, everyone. Could I have my presentation, please? Yes, thank you very much. So I'm here on behalf of the USAID HAD project, Health Evaluation and Applied Research Development Project, and I'm presenting work we have done it's been landscaping work to map community-based mental health interventions, policies, and actors across selected countries within Africa. So I'm here as Molly Naisanga, I'm a psychiatrist working with Infectious Disease Institute as a researcher, but it's been a team effort. Other people who have worked on this work, we have Dr. Stephen Okoboy, Dr. Jones right here with us, Dr. Manuel Mpamizo somewhere in the crowd, and Dr. Emily Pecker from the University Research Company. That's him. So where are we looking at this now? So if you may recall, in the 69 Health Ministers Conference, some commitments were made towards mental health. And in this, member states were urged to strengthen the capacity of human resource for health, for effective provision of mental health services, and also to develop, or if they already have, strengthen mental health policies and programs to guide service delivery in this area. Also, commitment was made to create an experts committee for mental health by the EXA Secretariat, Health Community Secretariat. So this is important because if we fail to address mental health, then we hinder productivity and economic growth. Yes, people are alive, but if they are mentally well, they're not able to function to maximum capacity. And also, depending on where you stand, anywhere from 3 to 16% of the population will have mental illness. Yet the system supposed to support these mentally ill people is heavily constrained in terms of resources. So that's why we need to do this work. So this particular work has been done across a couple of entities, not just Africa. We are also working with partners across Asia, Latin America, Eastern Europe. But for this particular presentation, we are going to just focus in on Africa. And what we are really doing is we are mapping community-based mental health interventions or programming. I'll get to define this in a little bit of a moment. We are also looking at policies, strategies, guidelines, and laws which support mental health across the countries where we are working. And we are also hoping to map experts and actors working within this particular space. We intend that this work will support multi-sectoral knowledge sharing and collaboration within this mental health space. So our definition for community-based mental health interventions is that they are either being offered at the district hospital level or at lower levels within our healthcare system. So we are not looking at things being done at the tertiary referral hospitals, no, district hospitals and below. And to qualify for this particular study, you need to have a means of diagnosing the mental illness, either by a questionnaire or you have a clinician on board who is doing the actual diagnosis. So it's not training, advocacy, right? No, you have to diagnose a mental illness. And the service may vary, may be integrated within an already existing system, maybe care for HIV people or something like that. It may be a public or private implementer. And the age groups from childhood to adulthood, across the whole lifespan. So our methods for this work included desk searches. We've done literature review to see what is published, what's in the grade literature. We've done some formal, informal interviews. We've reached out to different people from the different countries you come from, probably known to you, but we've talked to people from Lesotho, Mauritius, Ghana. Then we sent out an online survey, and we've also done a lot of consultation and networking efforts like we are doing in this forum right now. So this is the Africa region team. I've already talked about these particular members. And these are the countries that we're looking at. We are looking at about 13 countries, 13 African countries, extra states, and some other states which are not represented here today. So far, the work is still ongoing, but so far we've been able to come across 84 interventions across the states. The number of interventions for each country varied depending, but this work is still ongoing. Some had as many as 20, some as few as 1. Then our interventions that we came across, so we found modalities like psychotherapy. So because it was community-based, most of the psychotherapy interventions we found were group-based. So this is a talk therapy, but it is structured. There is a module on how you do it. So you gather together, patients have depression. This is what you do in session 1. This is what you do in session 2, something like that. Then counseling. Counseling is also talk therapy, but for the most part, it will not be structured. Then peer support. We may both have schizophrenia, but I'm in a better state than you, so I'm meant to support you to get you to a better place. Psychoeducation, conditional cash transfers. So we found some interesting interventions where they would measure mental health, maybe depression symptoms at the start of the intervention, then hand out cash transfers over maybe 6 months, couple it with maybe a talk therapy, then reassess and see if this actually works. Then there was art therapy, sports-based interventions, measure symptoms at the start of the football league, then measure symptoms after and see if this actually works. And community outreach is where, like the first speaker said, that NCDs, it's best if you reach out to people in the communities because they may not always be able to come to you in hospital. So these particular interventions, because of the nature of the interventions that they were community-based, it was a variety of cadres delivering them. We had mental health specialists, psychologists, student psychologists, psychiatric nurses. We had trained peers, people who also have the mental illness, but they've been trained to do this particular work. Parents in the homes where the patients come from, fathers, mothers, grandparents in the communities where they stay, community health workers who are the level 1, the level 1 of our healthcare system in most countries. We had people within the police system, or prisons, criminal justice system. And the venues varied because, like I said, it could not be in the hospital, regional referral or tertiary. No, that's not now community-based, that to be outside. So we had people giving interventions in homes, schools, to the students at different levels, primary, secondary, open community spaces, which had been designated for this purpose or which are multifunctional and they were just being used for this particular mental health interventions, refugee settlements, religious centers, mosques and churches, and then also some were being done virtually, like we were introduced to virtual things in COVID time. A variety of populations were looked into, from children, adolescents, people with particular diagnoses, because remember, key to our study, that there has to be a diagnosis you're looking at, and you should have showed us how you arrived at your diagnosis. Then also refugees, victims of trauma, maybe sexual and gender-based violence or some form of trauma, victims of children who have been in war. Then we have the people who have HIV or people with other medical conditions like nodding syndrome, caregivers of children with nodding syndrome, and then pregnant and lactating mothers. Then when we came to policies and strategies, again, we're looking across a number of countries, and it was reaching out to persons, extra contacts in those particular countries or individuals we may know in one way or the other. And we have 41 policies, strategies, and acts that we were able to come across thus far into our work. And we are happy to report that all the extra states had a mental health act in place. The ages varied. Some were older than others, others had been recently revised, others not, but at least there was something to start with. All states had mental health policies, save for Tanzania and Mauritius, who were not able to source that at that time. And then much as the policies were in place, the operational / implementation plans for most of these we couldn't find. We only were able to find for Zimbabwe, Kenya, Eswatini, and Lesotho. So for the last one, maybe we can pick it from the people we have here, because we could not find at the time on the internet. It's pertinent that you have a clear implementation plan for the mental health policy. Otherwise, if you just clump it with everything else, many times it just gets lost in the soup, as the World Health Organization recommends. Also, countries had other policies or plans which maybe were not labeled mental health, but were addressing other related issues like substances, child and adolescent mental health, suicide, issues like how should traditional and faith-based healers address mental health. Those were also policies and acts we found, we found. So as part of our data gathering exercise, we would like to invite your input towards this work. If there are some policies, some interventions which you think would interest us, you could scan this code. You also have flyers on your tables, or my colleague Emily right there. You could, her hand is up. She could hand you a flyer to. Then when you scan this code, it will lead you to a site where you can look at an Excel sheet of this work in detail. It details all the policies we have found, the interventions we found, but it also gives you an opportunity to give us feedback, to give us input of probably something we could not have included. Okay, all right. So also moving forward on this work, we will be creating a database of community-based mental health interventions across the regions, not just Africa, but also Asia and Latin America, the whole work together with a database of the different interventions, community-based mental health interventions we've been able to find. We'll also include the national policies, strategies, and acts we found which are useful towards mental health. Of course, for policies, for example, you can find them randomly on the internet, but this will be one place where you can find everything. And also expanding our learning network for knowledge exchange as part of the mental health and psychosocial learning collaborative. So this is a group which gathers every month. It's open, you're welcome to join. And basically it is knowledge sharing within the space of mental health, dissemination of data and other aspects of knowledge sharing.
Well, it should be concluding.
Okay, so this should be, I think, my second last slide. We look forward to leveraging EXA's Health Community Secretariat's regional collaboration role for convening, learning, exchange, and tracking progress in mental health and psychosocial support by enhancing a repository for mental health policies and programs on the Knowledge Hub for the EXA Health community. We also hope to engage members to be able to identify the priorities within the space of mental health, because there's so much you can do, but what is the priority for research and implementation? Then establishing an expert committee for mental health, like was agreed on in the 69th Health Ministers Conference. And then also tracking advancement of mental health implementation plans, where are we on, depending on the commitments made. Also promoting meaningful engagement of young people and people with lived experience of mental illnesses, and advancing prevention and promotion, not just treatment, but also prevention and promotion of mental health. Please feel free to connect with us, as you can sign up for the implementation sciences mailing list. So we don't just do mental health, we also do other things. If you could sign up to our mailing list, you could also follow up on our social media platforms, and we acknowledge support from USAID through the HUD project, which was implemented by University Research Company. Thank you so much.
Molly, will require you sit at the far end. We don't want you to go down back again. And I want to invite Mary Sando from Young People's Mental Health Being Initiative Landscape Analysis in Tanzania and Ghana. As I did indicate, keep noting some of the key recommendations we'll want to forward to the ministers. You are welcome. And the pointer is here. And I know the host Tanzania is always good at keeping time.
We'll see about that. Maybe the DG can confirm. Professor, you're Tanzanian now. What do you say about that comment? You say? You say? Professor says, he says, well, good morning, everyone. I would like to also stand on the pre-existing protocol. As introduced, my name is Mary Mwanyika-Sando. I work with the Africa Academy for Public Health. I've been honored and fortunate to serve as the Chief Executive Officer for the Academy for a couple of years now. Much as I noted that protocol is observed, I would like to acknowledge in the room presence of one of my teachers from medical school, Professor Said Aboud. If you may wave. Professor Said Aboud taught me microbiology in medical school at Muhimbili. Thank you. He currently is serving as the Director General for our National Medical Research Institute, NIMRI. So I'm here to share with you work that we did over a year plus on young people's mental health. The Africa Academy for Public Health, if I may shed a little light on our organization, was founded back in 2009. It is a Tanzanian non-governmental research institution that is also non-profit. We work to advance our mission on advancing research priorities in sub-Saharan Africa, and we do this through collaborative research, training and capacity building, and knowledge translation. We work with different stakeholders, partners, and collaborators within and outside Tanzania, and our main partner outside Tanzania has been the Harvard T.H. Chan School of Public Health. Areas of focus have included the spectrum of maternal and child health. Increasingly now, young people and adolescents come on board, but also areas of mental health, nutrition have been key and core to our work. Just to highlight a little bit on the ARISE network. In short, it stands for the Africa Research Implementation Science and Education Network. In 2014, June, 10 years ago this month, the AAPH and the Harvard T.H. Chan founded what we call the Africa Research Implementation Science and Education Network. It is a beacon of collaboration, uniting leading African institutions in a dynamic platform for groundbreaking research, transformative education, and sustainable partnerships across the region. Born out of a resounding call for enhancing public health capacity within Africa, the ARISE network emerged as a testament to collective vision and dedication of its founders. Together, as a network, we tirelessly work towards advancing implementation research in priority areas and look into nurturing the next generation of public health leaders. Through the South-South as well as North-South collaboration, we have been able to equitably do a lot of research in partnership, but also ensuring expertise is shared and voices are heard. This is the ARISE network. Towards end of this month, we will be celebrating our 10 years in Ethiopia with our collaborators there. Currently, we have 10 countries in sub-Saharan Africa, as you can see in the map, and our main collaborators in the north, including the Harvard T.H. Chan School of Public Health, who are co-conveners, as well as Heidelberg Institute of Global Health. We're very happy that our 10th country, Senegal, just recently joined us in this effort. So it is through this effort that when we saw the call of the Bing initiative that we were able to apply. The call was set out to, you can apply as a single country or apply as a multi-country. Because we already were working with Ghana, it was easy for us to apply in Tanzania and through our network to also include Ghana, which is among the 12 priority countries that the Bing initiative set out to want to understand what are the drivers of mental health and well-being among young people. So the Being Initiative is an international mental health initiative. It is hosted by Grand Challenges Canada. to tackle global challenges by understanding local solutions that build healthier and more equitable world for all of us. The Being Initiative promotes rights-based, culturally appropriate care that fosters supportive communities where young people are empowered as agents and drivers of change for improving their own mental health. The Being pillars include learning, investing, and mobilizing. With learning, it means to understand what is the landscape of mental health issues, what are the challenges. And with investing, it means investing in supporting especially youth-led organizations within our settings to advance and prioritize mental health improvement of young people in our subpart of our sub-Saharan Africa, but also to mobilize, that is an ideal, as well to bring and work with other donors and partners so that more funds can be brought in for more work to be done in advancing improvement of mental health. So through this exercise, as we all are aware, mental health, increasingly we see the evidence in social media, in communication, in evidence on research that's coming up, that it affects 13%. It contributes to 13% of the global burden of diseases among adolescents. And such issues, when encountered during this very critical period of growth, can really lead to poor coping skills for our young people, educational difficulties, but also physical ill health, and in many cases affects their progression in developing into healthier adults. Therefore, it is important that we identify these drivers and address them early with programs that are really context specific so that we can contribute to building a much healthier generation. So in the Learn pillar, the first pillar of the Being Initiative is the focus of my talk this morning. What we did was a landscaping analysis and went down to find what are the main drivers. And from there, results that have come out of this one-year initiative across the 12 countries of priority countries of the Being Initiative have been able to inform the second phase, the third phase, and hopefully beyond. So the objectives here for this work, for this study, were to summarize and synthesize available evidence within those 13 countries regarding mental health situation among young people. And for us, we applied and we were funded to support this work in Tanzania and Ghana. Following reviews after submission of my abstract, I kind of learned that we should more lean towards Tanzania. So I've removed findings from Ghana, but we have very similar challenges. So I'm only focusing on Tanzania. The second objective is to identify the critical gaps in existing evidence regarding mental health for young people, and then to conduct stakeholder consultations to summarize all these identified areas so that we can be able to bring all that feedback from the 12 countries and advance the next stages of this Being Initiative. So this is what I have been saying in terms of methodology. With the first part, it was just a desk review. Each country partner undertook robust landscape exercise to identify significant mental health issues facing the particular country, on youth drivers, on youth mental health challenges and what the drivers are. So we looked at government data, we looked at online searches through PubMed and all that, Google Scholar and everything. And we looked at studies between 2002 and 2023. And in doing so, we summarize all of that by also finding and looking at reports, including Gray literature. Having that information from the desk review, then we did stakeholder consultation. In the stakeholder consultation, it was really a diverse group. In all of the consultations, we prioritize youth concepts, youth-related concepts on mental health. And young people were very much part and parcel of these consultation groups. And with these, we worked within each country with the government stakeholders, researchers, academicians, people from non-governmental institutions implementing work, and youth people, young people, as well as people with lived experiences. It was important that young people are very much part of this process and were core. They were involved in the interviews and in the process. And then we also did online surveys. So in the whole process, this is just to highlight, as you see, colleagues there are my colleagues from the Africa Academy for Public Health. They're also young people, the two doctors, and next to them and around the table were young people. The groups were between 8 to 10 young people that came from the community, from higher learning institutions and different areas. So we engaged the youth to make sure that we really get the concept of what they think are drivers of challenges that they face. Following the consultations from different stakeholders, we came to the final step of our work, and this was consensus building. In this process, which we were fortunate to have held the consensus building right here in Arusha last year towards end of the year, during the first mental health conference, it was very fortunate for us because we were able to have an opportunity of almost every mental health expert in the room. And they were able to look at our findings and work together to prioritize and grade them according to their expertise on what should be the primary drivers and secondary and etc. And we did this through a voting after discussion. So in all of the countries, these stakeholders were brought together to determine and agree on what are the priority drivers for youth mental health and well-being. We asked them, following the consensus building exercise, to come up with what are the most critical issues and the top drivers contributing to young people's health, mental health and well-being. And it was through these consultations and consensus building exercises that within all those countries, including here in Tanzania, that the local stakeholders were able to articulate and come up with those context-specific drivers of mental health and well-being for young people. So what did we find from all this intensive desk review, consensus building exercise? Across the board, I'm also highlighting results from Tanzania. Depression in most of the literature and in discussions from the different stakeholders. As you recall, I mentioned that here it included clinicians who are actually mental health experts, clinical psychologists, and etc., who really see clients on a day-to-day basis from our health system, and those that are doing the research and training on mental health. 30% depression was found across the board. We also found anxiety around 30% in most of the literature. Substance use was also found at more than 10%, and suicidality more than 3%. It's very unfortunate that every other day one would hear of, the most recent I've heard is a 10-year-old young boy who came from school and hanged himself. So we keep hearing and seeing all these incidences, maybe because of availability of information through the internet, but it all culminates to telling us that we really have to do something about these gaps that we're seeing.
Mary, you should be concluding, though you are at results.
Excuse me?
Should be concluding, but I see you are just still at results.
I will be concluding shortly, thank you. So among the drivers that we were able to determine from our collective exercise included personal drivers, where young people feel they have low self-esteem, societal issues including peer pressure, cultural beliefs that maybe they are being bewitched, or parents thinking that that is the cause, but also urbanization and disease outbreak came out in the group of environmental. So this is more or less an approach that we used, and it was used across all of the countries that implemented the same methodology through the Being Initiative. So I would like to come to an end of my presentation this morning by highlighting the efforts also done by our government of Tanzania on young people's mental health. Tanzania has developed and is in the final stages of finalizing our very first mental health strategic plan. It is a very commendable effort. If you may please clap for our governments. Not everybody is clapping. At least the DG is clapping. So it is an important step, and we're very glad and proud that they've been able to bring this to life, and hopefully to be finalized and approved soon. It has been an intensive exercise with many stakeholders, a lot of support from WHO and so many other partners to ensure that at least we have a guiding document that can help us advance processes, building our programs and strategies towards improving health and mental health and well-being of young people and all the people of Tanzania. So definitely a coordinated approach involving local mental health experts and making sure that young people are part and parcel of that process is crucial, and addressing disparities on mental health for young people using evidence-based policies and interventions that are tailored in the cultural context is key. Early intervention is very important, meaning if it is programs that have to be included within the education system, if teachers have to be trained, it has to become, if it can become part of their curriculum, but beyond the psychology and other sessions of trainings that they receive, that mental health also takes up space so that they can, because our children spend a lot of time with their teachers, they may be a great platform to identify these early signs of possible challenges that may be taken care in advance early on, so that we can prevent a young person having a mental health challenge. Literature tells us that most young people may begin having mental health challenges or issues from as early as 14 years old. It picks up a lot from around 18. So this comes to the end of my presentation. These are some of the references that I'm happy to also share, and wish to thank you all for your attention and look forward to further discussion.
Thank you, Mary. A big clap for her. These issues of timekeeping can also cause mental issues to the chairs of the session. We have our last presentation. So want quickly to call on preventing blindness with early screening and treatment of three major blinding NCDs: diabetic retinopathy, glaucoma, and hypertensive retinopathy, by El Chaleses Adera. You're welcome. I'm very certain Adera will be able to be considerate of the chairs of the session.
Good morning, everybody. Allow me to observe all protocols. Today, I'll be representing Sightsavers and International Association for the Prevention of Blindness, IAPB. So my presentation is on 3 NCDs, which are causing blindness, and how we can manage them, or what the best practice for them is. Now, the first one is diabetes. So as most of us know, diabetes is rising in the world. The prevalence of diabetes as a disease is getting bigger and bigger. In the world, 537 million people are estimated to be living with diabetes mellitus. And one of the most common microvascular disease is diabetic retinopathy. So diabetes causes blindness by diabetic retinopathy, and microvascular disease is the whole essence of diabetes. That's how it causes disease in different organ bodies. One of the best approaches is to identify the microvascular pathology and treat it early. The eye being an optical organ, it has the option of treatment with laser, injections, and other methodologies that can be arresting the progress of the disease. So the main thing is to catch it early. Early diagnosis is the key to diabetic retinopathy treatment. The second blinding disease is glaucoma, and this is also another NCD. Glaucoma is also on the rise in the world. It is the increased pressure in the eye, which causes pressure on the optic nerve, resulting in nerve damage and blindness. And as an NCD, this is also one of the main causes of blindness. In the world, WHO estimates that 2.2 billion people live with visual impairment, and 1 billion people are living with preventable blindness or preventable visual loss. So 1 billion people are living with visual impairment, which is not really necessary or which can be prevented. And one of them is glaucoma. And to prevent glaucoma, again, it is an early diagnosis, early treatment disease, and the method of diagnosing is much more or less similar to that of diabetes. The third disease is hypertension. Hypertension is also an NCD, which is on the rise. It's estimated that 48% of the people in Africa live with hypertension. These are women, and 34% in men have hypertension. Hypertension has different stages, the mild, moderate, and severe, and all stages have been shown to have retinopathy. And the retinopathy of hypertension again causes damage in the retina, which can lead to visual impairment. Again, the methodology of treatment for hypertensive retinopathy is early diagnosis and treatment. So what I'm presenting is a systematic review, which was done from 1983 to 1999. This reviewed all the English literatures which were published on diabetic retinopathy and how to diagnose it early and how to manage it. So the methodology was to review all the literatures, and what the researchers found was that the best methodology to diagnose early is to use a dilated examination using a fundus photography. So fundus photography is taking a picture of the fundus, which used to be very difficult in the past, but now it is advanced in technology, is becoming more and more easier. So pictures can be captured of the fundus, and they can be shared with other ophthalmologists, or pictures can be captured by nurses and shared with ophthalmologists for review, and diagnosis will be made, and then treatment can be made after that. The same methodology can be used for diagnosing glaucoma and diagnosing hypertensive retinopathy. And the researchers showed that the mydriatic or dilated examination is the best for identifying the disease. It could be with fundus photography, but if the photography is not credible or if it's difficult, then direct ophthalmoscopy or indirect ophthalmoscopy, which is also another tool which can easily be purchased, procured, and supplied, could be used. So the two combined modalities, fundus photography with a dilated fundus and ophthalmoscopy with a direct or indirect ophthalmoscope, are the best mechanisms to diagnose, identify early diabetic retinopathy, glaucoma, and hypertensive retinopathy, and then make it possible for people to treat it. So the conclusion is we need to equip secondary eye units, secondary hospitals with the equipment and the knowledge on how to do a dilated fundus photography or dilated ophthalmoscopic examination, so that the human resource who are available at that level can diagnose diabetic retinopathy, hypertensive retinopathy, and glaucoma, and then they will be able to refer them for treatment or treat them in the same facility, enabling the prevention of 3 of the main NCD cause of blindness. Thank you.
A big hand clap for the last presenter. I should have made him to start so that he would have been able to show the way. Due to constraints of time, I will want that you will be able to reach to the presenters later because we need to catch up with time. On your tables, you have notebooks. I would like you to write down. I have some 2 questions here, which I will want you to, as you listen to the other presentation, write down. From what you listen from these presentations, what are the policy recommendations do you propose for EXA health member states and Africa as a whole? Second is, as an implementing partner, how will you support to see the region is embracing such best practices to have those have been presented to bring impact in the EXA health community and also the member states. Let me just recap. What are the policy recommendations do you propose for EXA health member states and Africa as a whole? As an implementing partner, how will you support to see the region is embracing such best practices you have presented to bring impact in EXA health community and the member states? My colleague will be, after probably 1 hour, 30 minutes, will move around and pick those from you. And so let's big a hand clap for the presenters. And also at this point, I want officially to take over, and hand over to the organizing committee. Thank you very much.
Not so bad. Please, we are keeping up with time. A round of applause to our chairperson, please. And the presenters. Thank you so much. The morning break has been amazing. Now we're going for tea break, and with the conscious of time management, I hope we will be back in a very short time. So we expect to see you here by 10:30. By 10:30. Enjoy your breakfast. Dear participants, ladies and gentlemen, we are moving to the next session, and this will take us to the panel discussion impact on health. And the chairperson will be Dr. Prithviraj Rampati from Mauritius. May I humbly let you on the stage, Mr. Chairperson. No, we can start.
Okay. Okay, welcome back to this session, new themes. Start by waking you up. After your tea, of course, you're already awake. So two simple questions before we move on to mitigating climate change impact on health. My question is Almighty always right? You can raise your arm to this question. Is Almighty always right? Very simple question. No, you have to say yes, no. Yes, no. You're starting doubting him, is it? No? No, he's always right? He's always right. Okay. Is he fair? Is he fair? You raise your arm. Be open. Is he fair? Yeah, he's fair also, but I don't think so. With so much of so much of trouble on our plate in healthcare, NCD, infectious diseases, substance abuse, and so on and so forth. Now we have a new thing to manage, and that is mitigating climate change and its impact on health. All right? So let's see how EXA-HC can bring all of us together to discuss on this subject. Climate change is just not an environmental issue. It is a profound health crisis affecting communities worldwide. The EXA region is particularly vulnerable to the health impact of climate change, which exacerbate existing health challenges and create new ones. From increased frequency to extreme weather events to the spread of vector-borne disease, waterborne, and other infectious diseases, the repercussion of changing climate poses a significant threat to the health and well-being of our population. We are going to invite Mrs. Paulina Ome from IGAD to have a presentation, and then we will be followed by a panel discussion. I'm lucky to have only one presentation so that we have enough time for discussion. Thank you. Welcome. Yeah. Yeah. Paulina, did I say right? Okay. Thank you.
Good morning, everyone. While my presentation is still coming on the screen, I want to appreciate the organizers and all delegates, countries representative, our international regional partners, the leadership of East Central Africa and Southern part, health community in general. I want to appreciate you for a very good work and well-organized meeting or conference. My apology, I arrived very late yesterday. I supposed to catch up with yesterday's session. My flight been shifted to afternoon, therefore I couldn't manage to be part of your discussion for yesterday. As all of us, we know climate change is a real and impact being felt everywhere. and it is very important for us to deal with the consequences. Therefore, I'm standing here on behalf of my colleagues from IGAD, which is intergovernmental. Climate Prediction and Application Center, known by ICPAC. It's not moving. Next, please, if you're able to move the slide. I want to just to go very quick on the climate and health nexus. Under IGAD or ICPAC, we have many activities, at least to tackle the impact and also the evidence behind the climate. One of the very important areas we're able to really do much better are the areas dealing with the climate monitoring, also capacity building in terms of producing this climate information and disseminating them into the end user. Because if this good climate information they are not able to reach to end user, mean we are not able to also reduce the risk or also anticipate expected risk. Therefore, also we are dealing with some application in terms of key socio-economic sectors, in terms of agriculture, disaster risk management, water resources, and also some cross sectors where you're able to find more effort should be dealt with through cooperation between the all institutions. Next. When we deal with the climate or when we talk about the climate, it is very, very important for us to know the scientific evidence and also the trend. One of the messages, and it is very important for every one of us to really to take home, the climate is real. The intensity of the climate and frequency of extreme events are increasing and also increasing every year. So if you look at the variability in the extreme climate event within the last 10 years, you find the variability and intensity frequencies of this extreme have been increasing in all countries. Therefore, it is very, very important for us to prepare and also to take action. If you look at the impact of El Nino as one of phenomena also driving the extreme event, like what happened in Kenya 2024 this year, is one of the wettest year in the record. If you go back to 2022, 2021 was also one of the driest years in the record. So you find the extreme event in terms of wet and dry condition become back to back. Therefore, it is very, very important for us to prepare more for how we can reduce the impact. If you look at the impact for 2024, if you compare that one before 10 years, the significant impact of the recent one are very, very significant and also very strong, and also the impact was going into many socioeconomic sectors. Next. Then again, when you look at the future, what's going to happen based on what we have for now? If we still continue with business as usual, where now we're able to pollute more and more, what's going to happen in future, putting into account the current circumstances of the climate or the trend for today and the different scenarios? So it is very, very clear if we doing business as usual, where now we are not able to take climate action seriously, the temperature in our region is increasing. Even not only our region, all over Africa continent, temperature increasing. then it's going to continue increasing year by year in the next centuries. Therefore, it is very, very important for us to prepare as a health practitioner how we can reduce this impact. And it is very, very clear if you compare the graph or the models, the one in green, with the models where we are considering business as usual in red, the temperature increasing and the level of the increasing also is very, very high if you compare the one in green, the one in blue, and also the red. So adaptation, mitigation action are very, very important for all socioeconomic sectors. Putting into account, there are some changes also in the recent years. When you see like southeastern Ethiopia, some part of central, and also going to northeastern Kenya, where the decline in amount of rainfall. Recently, those areas also, the signal have been recovered because of extreme rainfall event, the one in 2018, 2019, and also 2024. Therefore, the intensity of extreme also we have to consider when we are taking action next. Again, if you look at the nexus, the high temperature, the extreme rainfall event in terms of the flooding, in terms of drought, and also heat wave, all of them has a very negative impact, very significant impact on the health sector in terms of outbreak of waterborne disease, contribute through contamination of water when there is a flooding, and also the heat wave because of high temperature also can be caused directly or through the direct impact because of the high temperature, where there are other underlying conditions will be very, very seen clearly. And also the most vulnerable groups, such as less fortunate communities, and also underlying health condition, all of them elderly and also children. These are most vulnerable group. So therefore, it is very, very important for us to think about action can be taken for us able to tackle the impact and also reduce the vulnerability of this extreme event, whether changing in the daily temperature or seasonal, or also in terms of the annual or the seasonal variation. Next. Then again, when you look at the building blocks, it is very, very important for us. If you look at these building blocks, it is not action can be done by one person. Need really a comprehensive working together at the regional actors, national actors, at the national level, local level, and also international level for us able to overcome these building blocks. Then again, also, it is very, very important for us to acknowledge the type of information or climate information in different time scale are very important, whether information given at the daily basis, weekly, 3 days, monthly, seasonal, and also projected in the future. All this information are very important for us able to prepare for now and also anticipated risks in the future. Next thing, point out the issue. Yeah, and also very important for us to know the profile, risk profile for now. Which areas has a very high vulnerability, which areas also has a low vulnerability. Because if you talk about climate change and we don't know the risk, which areas has more vulnerable than others, it is very important for us. It is not going to be business as usual for us able to develop action. This action should be also as a priority based on the level of people under the risk are also affected more. And also the type of the risk being anticipated, not just talk about the climate change. We need to see which type of extreme event really they're affecting and how they're going to change in the future for us also to develop more concrete action. Next. For ICPAC, we really went ahead to develop some system where information or early warning can be utilized by people. Some of the action been taken for us to really transform or change our climate information into a platform where everyone can able to access this information, and also for you able to get the level of your risk and also anticipated risk and also early warning. Then early action can be taken based on this information. One of these platform is a climate hazard watch, where we're able to give more information on the weekly, seasonal, and also more than season. Also, some projection for next 30 years, next 70 years, for us also to able to prepare for this risk, how they're going to change based on the trend in the present time, then how they're going to change in the future under different scenarios. And all of them are very important for us able to monitor this hazard and also give forecasting in a good time. Then you're able to take action based on which type of risk you are going to face, where exactly. Then by click, you can able to get information for your place. Thank you. No, sorry. I still have some more. Next. Yeah, this is some of the platform, agriculture watch, drought watch, flood watch, where now you're able to see this is extreme event. They're very, very important for the health practitioners. If we are not able to take action for now, things going to be complicated in the future. So for ICPAC, we're able to give early warning in terms of drought, which area is going to experience drought or which area is also expected to experience flooding in a very good time. Next. Then that information given through IGA Disaster Risk Operation Center based in ICPAC in Nairobi, where we're able to give the all extreme climate event early warning, and also able to give some direction on early action can be taken based on this extreme event. Next. Next. Based on the seasonal information we producing and also disseminating every 3 months, one of the platform is called Greater Honor Africa Climate Outlook. This forum is very, very important for us able to really disseminate information, and also key sectors can be invited, and also they're able to anticipate the risk, which action can be taken. So if you look at the health sector working group, we're able to see these areas they're expected to get more flooding or more drought, which action can be taken for the health practitioner for them able to prepare more based on the anticipated water or vector-borne disease. Next. Then again, it is very important for us to know the component of the risk itself, where now we're able to give more information on the health foundations as a baseline, and also facilities, because the response is very important for us to look into the whole system in general, not just taking action based on one, but should be integrated emergency and also lifeline infrastructure for response. Because if you don't have a good infrastructure, even this type of information you got very early, it will be difficult for you able to take action, because the action will be based on the level of the foundation you build, and also facilities, and also the system in general. Next. Next. Also, it is very important for us also, once we are doing very good, it's good for us also to assess where are we, which areas we are not able to do, and we need to do much better. So we need to do much better in the health risk profile, and also hazard monitoring, where we're able to put multi-sectoral and also early warning for the all sectors. And also it is very important for us to do more preparedness planning for the risk, and also predetermined anticipatory action could be also areas we need to work more on it for us able to strengthen the health and climate nexus or WASH in general, where we're able to put all pillars together. Then we strengthen the engagement between the all stakeholders as term of the good practice, where we're able to showcase on the co-protection between the all entities. I can raise my case for now. Thank you.
Thank you. Thank you, Polino. Round of applause for him. We can see his enthusiasm in the climate change issue and his meteorological background, I suppose. Okay. I would like to invite members from Kenya, Zambia, Zimbabwe, Malawi to take the front stage for some panel discussion. Yeah. Kenya, please. Zambia, Kenya. Yeah, we got. And then geotechnology. You're from geotechnology, somebody? Yeah. Geotechnology? Yeah, okay. Thank you. To just break the ice, let me share some experiences from Mauritius. I believe we are a small island. We are a small island, and we are told that the sea level is rising 1 centimeter every year. Am I correct? Due to temperature rise. So we are in the heart of Exile course, but we want Exile to prepare in case Mauritius get drowned. We can have a place in the mainland, right? Okay. So hope that is done and take a note of. Yeah. The second issue is, let me share some other thing about anecdote about some of the climate changes that Mauritius faced recently. In the last 7 years or so, we had 2 torrential rains, flash flood rains. And in the first one, we lost 10 people because of flash flood. And the second, which was only few months back, we lost 2 people in the flash flood. So this one climate change, small island state managing things can be difficult. You said resilience of healthcare system somewhere. I think COVID gave us a very good experience. And COVID and climate changes, if you look, the way to approach it is more or less the same. Your system has to be prepared for the worst case scenario. In COVID, although our services were running not to the fullest spectrum, but services, so hospital was still running. And luckily, our primary care was so well established that many of these people turned to the primary health care. And so we learned from a good lesson that we really need to invest a lot more and improve on the service in the primary healthcare. Yeah, so we go for the round of question. So my question to Kenya panelists here is, what are some of the most pressing health issues linked to climate change that your country is currently facing? Kenya has had a devastating flooding situation during the month of April and May. Would you tell us more about this? Kenya.
Thank you very much. I think the presentation from IGAD has really set the stage. Indeed, it's true in Kenya, we have had really severe changes. For example, in 2020, from 2020 to 2022, we had severe drought. And then in late 2023, from October 2023 to early this year, we've had excessive El Nino induced heavy rains with flash flooding and displacement of people. And the impact has been great. I think from when we had a lot of drought in 2020 to 2023, there was impact on food security with malnutrition, cases of malnutrition, and nutrition particularly, and micronutrient deficiencies. We also had changes in vector-borne diseases. So areas where we previously, for example, will not see malaria, you'll find that you have malaria there, particularly in the northeastern regions. And these have been due to the changes in mosquito breeding areas and mosquito patterns. We now have diseases such as dengue rising in Kenya, as well as even chikungunya. You know, we've not had, previously we didn't have such emerging diseases such as chikungunya virus, but now is something that we have in Kenya. We have not been spared from the food and waterborne illnesses. the situation that was being discussed about yesterday, cholera in Africa. Kenya has also had increasing incidences of cholera in a number of regions. We have been impacted on mental health. And now you have these terms such as climate depression, climate distress, when people are displaced from their homes and they live in makeshift areas or in school, and without knowing where next they will go. Yeah, so I think it's quite a lot to enumerate. So the impact of this climate change in Kenya, it has been severe. I think I can leave it at that so that the other panelists can also.
Yeah, okay. Thank you, my dear friend, for having such a clear explanation of what happened in your country, and that you engage all the supposed stakeholders to manage it. What is most important to understand with climate change is you're not finished with one, and the next one is already ready to strike you. So it's an ongoing process, just like chronic disease with sequelae coming in one after another. So this is what we need to be taking care of. My question goes to Zambia. How can national and local government better integrate health consideration into climate change policies? What are some successful policy initiatives that have helped mitigate health risks associated with climate change in Zambia?
Thank you, Chair. Greetings from the Zambia team. Our government has been very proactive and forthcoming on ensuring that we mitigate the health effects as a result of climate change. There is a policy that is looking at decentralization in the manner we provide government services, particularly healthcare services. And this has given a lot of responsibilities in terms of leadership and governance to the local authorities, starting at district level, provincial and national level. So the decentralization policy is one successful policy that is ensuring that we continue to attain universal health coverage using primary healthcare interventions in order for us to improve equity of access to quality healthcare services across the country, including areas that are severely affected by climate change. Another successful policy is that of institutionalizing and ensuring that the National Disaster Management and Mitigation Unit responds very, very effectively across all the levels of governance. So this structure is integrated at district level, is integrated at provincial and national level, and works in a multi-sectoral manner whereby all the leaderships, from the political leadership, the traditional leadership, and key institutions such as the church, as well as the education sector, are all part of the response to mitigate and manage the challenges that we are facing as a country as a result of the changes in weather patterns. I must also mention another institution, which is the National Food and Nutrition Commission, which is ensuring that partners come together, coordinate, and respond to the challenges of undernutrition across the country through sensitization. The government has also heightened the response through key ministries such as agriculture, as well as fisheries and livestock, and also community development. Under community development, disadvantaged members of the community are identified and are put on a monthly social cash transfer. This social cash transfer is a game changer in the sense that poverty is alleviated in these families. So they have a criteria under which individuals are identified who can benefit from monthly cash payments. The security wing has also not been left behind. We have the Zambia National Service as well as the Prison Service, who have taken up an active role in agriculture by heightening and improving and increasing their agriculture production. So this is affecting to minimize the effects of undernutrition. As a health sector, we have also ensured that we integrate key services by ensuring that we improve on surveillance. As you know, with climate change, issues of mental health, diarrhea, as well as malaria need to be managed. We've improved on risk communication, and we have ensured that we work in a multi-sectoral manner with all the key stakeholders that help us to respond positively as Minister of Health. In the area of energy, the government is promoting alternative sources of energy. Zambia generally depends on hydroelectric generation. With the drought that we are currently facing, our capacity has significantly reduced. So alternative sources of energy such as solar are helping us to maintain, say, the vaccine chain, as well as continue production of health services in our facilities. The government is also looking at issues of managing the taxation to reduce the burden of taxation on equipment, such as equipment for production of solar energy in health facilities. Lastly, the government is working very well with the community to ensure that we minimize the negative effects of community activities such as tree cutting for charcoal burning, and also ensuring that we manage the groundwater by actively following up and registering on who is drilling a bore, where, at what depth, and so on and so forth. I think I will end there for now. Thank you.
Thank you, Zambia, for having such a clear picture of what's going on in Zambia with regard to climate change. I suppose all those extra member states by now must have a risk disaster management center. Am I correct? All of us? Anybody? No? Yeah, so that's a great starting point, I suppose, where we need to build around this infrastructure system so that we are almost ready almost all the time. Of course, we can't manage everything. So my question to Zimbabwe, how can communities be better informed and educated about the health risk posed by clinical change, climate change, and their role on mitigating the climatic change? How can health sector system be strengthened to respond to the health impact of climate change? What are the key components of an effective climate resilient healthcare system for Zimbabwe and for people around? Yep.
Thank you very much, Mr. Chairman. I'm a public health specialist from Zimbabwe, and we are here to launch the College of Public Health here within EXA, together with our colleagues from SADC. SADC and EXA work very closely together. One of the key disciplines of public health is environmental health. Environmental health. And I want to ask how many of you here are environmental health specialists? At least we have one person here.
Yeah.
Environmental health specialists are a key foundation of our health systems, and they work on the ground with the communities and families. So that's why I emphasize the issue of environmental health specialists in the debate on climate. The second point is communities are always faced not just with climate change on a long term. Every year, seasonally, they have to face the rains, not enough rains, nutrition, flooding, adequate water for sanitation, hygiene, etc. So these are every year changes in issues which communities have to face. On the health side, this affects their nutrition, it affects their vector-borne diseases like malaria, other issues like eclampsia and maternal health, and you have heard hypertension, stroke, etc. So those are the health risks faced by the communities. Now the question is, how can communities respond better and be informed and educated? But more important, with changing attitudes and practices. Education is not enough. It has to be supported with changing attitudes and behavior. And the only way it happens is through the community health workers, supported by the primary health care system, from the health posts, health centers, the environmental health technicians, the nurses. They are the ones who continue to inform, educate, mobilize, and support the communities. So that's the most important element. If our primary health care system is not strong, our district health system is not strong, then our ability to support the communities is very limited. And how do we support them? Kenya has one of the best examples, very easy, trees and more trees around the health post, around the communities. It's not difficult, supported with our forestry health services through our local government. So communities have more trees, you have the challenges of a good shade, you have an environment, no flooding and etc. In fact, in some cases, it causes more rain. So trees are a very important intervention for communities and affordable, but supported as well. The other element is, you heard from my colleague here from Zambia, solar power. It's affordable, but it has to be enhanced to communities so that they don't have to completely depend on firewood. Now, firewood can degrade the environment and increase the risk of flooding. So that's another area where solar power support, and all our health facilities should also have solar power. All our health facilities and healthcare systems should be an example to have adequate trees. So the issue of water supply for communities is essential. So those are some of the areas where I think our health system can be strengthened to provide support on avoiding the risks of, and the other one I forgot to mention again with the trees is for nutrition. How many of us have worked on helping communities with nutrition gardens? Those are another very simple effect, but they have an impact on good environmental health and climate change. So the key people who can drive this in the health system is the environmental health workers. Of course, we need the national policy. We need to work with local government. We need to work with agriculture. But if the health system is to respond, one, primary health care, community health workers, environmental health technicians, and then the support down the line. Thank you, Mr. Chair.
Thank you, Zimbabwe, for such a lucid picture of how we can proceed with community health worker engagement in primary care to help us with climate change and including solar panel in all our health services. My next question goes to Malawi. How can different sectors, health, environment, agriculture, and among others, collaborate more effectively to mitigate climate change impact on health? And one example from Malawi.
Okay. Thank you very much. So here in order to get the different sectors to work together, I would imagine that the first thing is leadership. Leadership in climate change and leadership in health. This leadership can be, existing, pre-existing, or it needs to be developed, because if the different sectors are not working together, it points to a lack of leadership. And sometimes leadership need to be encouraged to think multisectoral. That encouragement can be through funding or technical support, where people that are accessing funding are increasingly being reminded that climate change and health is a multisectoral project, not just one one sector. At the governmental level, that also needs to happen, that the leadership must identify that not one ministry or department or agency of government can handle climate change and health in and of itself. So that calls for that sort of recognition. There's need to think together, the different sectors to think together. It cannot be agriculture thinking about climate change and health on their own, or health ministries on their own. There's need, I mean, that can happen, but there's need to have platforms where corporate thinking, joint strategizing and activity planning ought to happen. Joint monitoring needs and reporting needs to happen. So that needs to be inculcated in various the various sectors, including in education. That those in health, when they are dealing with climate change and health, there is also input from the people from agriculture, people from weather and meteorology, and that becomes the norm, because climate change and health will not be tackled by one sector at the exclusion of the other. Climate change is one such area that we should remind us that health is multisectoral in all its manifestation. So that needs to happen. Now, I'll give an example just to buttress what we experienced in Malawi. During El Nino, we had opposite weather manifestation, flooding on one hand and then drought on the other. As people went into the camps, the focus was on food and water. Very few, and in the planning, did we think about business continuity in terms of provision of health services, family planning and sexual health, mental health, and all those sorts of things. These can be tackled if at the beginning, at the preparation, as we look forward, as we mitigate climate change and health issues, we work together as groups. I'll finish here because time, technical working groups that we do have in our ministries and elsewhere. There is need to bring different working groups from the different expertise from across ministries, from state and non-state actors, civil society, NGOs need to be part of that. So that leadership needs to be developed and need to be developed yesterday. Thank you.
Thank you. Thank you, Malawi. You mentioned leadership in climate management. Certainly, once you have leadership, of course, you need to have ease of doing the business around the climate change. Sometimes the activities doesn't flow seamlessly and lots of difficulties arise. But once we have a risk management center and people are prepared to deliver climate change response, things can get better. I turn to geotechnologies for his question, but before I ask him a question, I would like to share something that we did in Mauritius. Recently, we had dengue outbreak, and we used drone to spray medication, pesticides to deal with this outbreak. And that was something very new for Mauritius. So this is how, of course, usual fogging goes on, but hard to reach areas, we had to use drone for that as an experiment. So turning to geotechnologies, how can technology and innovation be leveraged to mitigate the health impact of climate change? Mr. Manoj Prabhu.
Thank you, Chair, for the question. So firstly, I'd like to thank Director General, ICSA team and the entire ICSA team for organizing such a lovely event and touching upon some of the core topics like climate change. Now, coming to the topic of how digital health or the technologies can impact climate change, there are various ways in which this could happen. So in different countries and also at a regional level, the systems are working in silos. For example, there are different health systems. There are different data sources from the climate change program. So in order to resolve or address this problem, it's important to have a One Health concept or a One Health model for universal health coverage, which will be interoperable in nature and try to address most of the concerns. So to give you certain examples, one could be predictive analysis and early warning systems. So building a situation room which allows us to collaborate with multiple data sources. So just to give you an example, let's say if there is already data around malaria prevalence and there is data around heat waves within a country. So to correlate that data and give us that kind of early warning signs and symptoms that will make us ready for pandemic preparedness. The second could be making use of Internet of Things, that is IoT devices. So using IoT devices, and since it has sensors, one can simply predict, on what is going to happen. And with the help of data from past 5 years, using predictive analysis like Power BI and different analytics and AI and natural language processing, it can allow us to give us information on what is it that would happen, based on the data that is already collected. What is it that would happen in the next 3 months or next 6 months, based on the current ecosystem. Second is having an mHealth tool, again, part of the One Health ecosystem, which allows the communities at the last mile to get the right kind of information. So if we want to be pandemic prepared, so it's important that we have SBCC modules like standard mHealth applications, which can give us social and behavioral change communication. That is the right kind of information at the right time. Secondly, for people who do not have, or the communities who do not have access to health facilities, and if they are staying at some remote areas, and because of certain changes in the climate, there could be teleconsultation and telemedicining that could happen using the tool. And this will allow even the people or the communities at the last mile to get the right kind of access in spite of their location. And lastly, making data actionable and for use. So having that kind of situation room and having that kind of programmatic dashboard would allow the program and the different stakeholders, it'll make the data actionable and use, so that it can allow the different stakeholders for the right kind of policy advocacy and decision making. So of course, AI and other aspects have evolved over time. There's already a lot of work happening in countries. All we have to do is make systems interoperable in nature and make it part. Thank you. And make it part of One Health as a part of the universal health coverage. So with this, I'll take a pause. And again, thank you, Chair, for that lovely question. Would be happy
Thank
to
you,
answer
thank
questions.
you. I'll extend a bit on this question, if you don't mind. Whenever we have climate disasters, often there's power breakdown, and IT segment run on powers. So how do you find to get across this problem?
Sure. So in order to scale across that problem, so there's already a lot of work. Even in fact, countries like Nigeria, at a Ministry of Health level, have just introduced a situation room. All they had to do is get different stakeholders on the ground, get different approvals and buy-ins from the national program, and then build one common ecosystem. It's very much possible, and even countries within West Africa or Central Africa have been implementing this, wherein they have these kind of early warning signs, because COVID made us think that we never knew that this is something that could happen. And there were scenarios wherein there were lockdowns, people are not able to move, not get the right kind of services. So even countries like South Africa and others have made certain systems available by making it interoperable in nature.
Thank you, sir. Okay, move on to IGAD. Would you tell us more about IGAD Climate Prediction Center and how the center can serve the region on climate adaptation and mitigation intervention?
Thank you very much, Chair, once again. IGPAC is the stand on IGAD Climate Prediction and Application Center. When you look at the IGAD, the regional intergovernmental authority on the development, which has 4 key mandates, where IGAD aiming to promote regional integration, also to deliver on the peace and security, then on the environmental protection. Then the fourth pillar is on the social development. So IGAD anchored on protection of the climate, on IGAD Climate Prediction and Application Center, ICPAC, based in Nairobi, where we are able to give timely, accurate, reliable climate information on the past, the present time, and also in the future. So this information being delivered at the different time scale or time step where we are able to prepare early warning, early action advisories to different socio-economic sectors, whether health sector, agriculture, food security, disaster risk management, water and energy sector. All those information, we package them on the weekly basis, monthly, seasonal, which is 3 months. And also we have forums to implement and disseminate this information, a part of disseminating this information through direct communication with the end user. For IGAD able to deliver his mandate, ICPAC as some regional and international partners. ICPAC is a regional climate center coordinating the climate issues on behalf of World Meteorology Organization. And also we are a center of water excellence center for application, and also we are doing more on the disaster risk management. So on the delivering the mandate for WMO, which is World Meteorology Organization, we are able also to coordinate the 11 countries. IGAD serving 8 countries, but ICPAC or IGAD Climate Prediction Application Center, we are serving IGAD 8 countries plus Tanzania, Burundi, and Rwanda. Then we are serving our mandate on the 11 countries because climate has no border. We are not just strict on the IGAD region alone. Then also we are working with many actors at the national, regional, and we have the focal point. The focal point for the IGAD or the direct communication with the countries is a permanent representative of every country with the World Meteorology Organization, because all meteorological department, they are representing their countries with WMO. So the focal point for communication with the countries is starting from the directors of the MED services in all IGAD and non-IGAD countries. So for us able to deliver our mandate where we are fostering climate services, we rely on the communication direct with the end user, and also we are able to deliver on the early warning in terms of giving information on the risk, anticipated risk, and also action can be taken by the countries for them able to adapt into the situation. And also we working on the climate change action where we are able to reduce the risk through the information, and also effort on the mitigating the main root cause, which is greenhouse gases emission, through advisories into clean energy or application where the greenhouse gases emission will be reduced, which is the main mandate for mitigation action. Thank you.
Thank you, Aigan. I would like to take this opportunity to thank all the panelists from Kenya, Zambia, Zimbabwe, Malawi, Geotechnology, and Aigan for this very elucidative discussion. I will open the floor for discussion from the members out there in the floor, right? My question is open for any question from the panelists. Any clarification, anything? I'm sure by now you cannot be sleeping on your pillow now. All right. Okay. And because climate change is so ever evolving, you never know what next tomorrow. when to say, are we really prepared? Are we ready for it? I'm not very sure. But I think with the collaborative work by EXA and HC, probably we can share information, get collaborative work, get some consultative action among ourselves, wherever there are weaknesses, and we can get things done in a better way. So we have somebody from there?
The person was here.
Yeah?
Okay.
Present yourself so that's easier for us to get the picture. You can raise your hand, but I can't see you.
Oh,
Yeah,
okay. I thought you are okay.
Thank you very much, the moderator and the panelists. My name is Ambrose Talisuna. I work with the WHO liaison office to the African Union and the United Nations Economic Commission in Addis Ababa. Previously, I was regional advisor for health security in Brazzaville. And I would like to make an appeal to all of us, and this is really a critical discussion, the climate health nexus, and how much we want to talk about the investment case for preparedness. If you look at the investment that IGAD has done, it's highly possible that now we can document how many disasters didn't occur, how many epidemics were mitigated, how many epidemics were of a shorter duration. And we should communicate that to have the investment case for preparedness. We commonly talk about how big the outbreak was. Ebola was big, cholera was big. But we don't talk about the cholera outbreak that has been nipped in the bud, for example, in Zambia recently. I want us to start speaking this language because preparedness really is the investment case. When we succeed with preparedness, things don't occur, unfortunately. And so can we start communicating about disasters that didn't occur or disasters whose peak was dented, disasters whose duration was narrowed? We analyzed data for Uganda that looked at Ebola outbreaks from 2000. And Uganda has continued to have Ebola outbreaks, but each Ebola outbreak is of a shorter duration and a lower magnitude. And that's the investment case for preparedness. So it's my appeal to you. Kenya, for example, how many malaria outbreaks have you nipped in the bud due to recent floods? We don't communicate that good. I really want us to start communicating that good because it is an investment case for preparedness. You have some success stories. Zambia, for example, now you have nipped a cholera outbreak in the bud, but we are not talking about it. I thank you.
Absolutely right. Yeah, absolutely right. So much of work is being done and all the preparedness activities. I think post action, always there has to be some form of refresher activities to understand how effectively we manage the process, what are our weaknesses, and how we can be better prepared. Can I have the next question, please?
Okay. Afternoon. My name is Dr. Danny Goto. I represent Equinet. Thank you for the panelists representing the respective countries. As Equinet, we are working regionally in trying to tease out solutions across the Eastern Southern Africa region. I'm laboring to see the connectedness of all these countries in terms of strategy, approach, or solutions. So this being a gathering for best practices, I would be really excited if I can listen to the panelists what is happening at a regional level that is connecting, because I know there is no single country that can address climate change. No single country is prepared enough, even for simple things like food security that we've talked about. The second aspect is financing these initiatives. No single country can tell me right now that they have a designated budget for even an aspect of climate change that cuts across the region, or they are working on collectively or within their respective countries. So that maybe should be a really strong conversation in a gathering like this so that we can go back and say, what are the critical pointers that we can pursue as a region? Engage the leaders in the respective countries to see how are you connecting with Kenya? How are you connecting with Tanzania or Malawi or Zimbabwe? How can we think about these climate issues collectively? Invest resources collectively without just being beggars in different spaces. Thank you.
Yeah, thank you. Thank you. Yeah, you remind me of the financial crisis that even the richest countries had during COVID. They were all down on their knees. Leave aside poor countries and low status countries. How are we going to manage resources, finances? Even the best resources cannot be put together sometimes. Okay, finance can be a very limiting factor, but I suppose from my experience in dealing with some of these disasters we had in Mauritius, community mobilization is probably one of the best way. It just happened automatically. But if our communities are prepared to deal with, just like we have simulation for fires, outbreak somewhere, or just something like there's a flood, how do we go around it? So I think some preparedness is important, and I believe two areas: preparedness, action, and post-action. How do we know how we really done the job the way we do it? Can I have a mic, please?
All right. Thank you very much, Chair, and thank you very much, colleagues. Listen, Trey, I think a lot of discussions have been around integration of climate change and other aspects of human development. So I just wanted to understand in terms of our colleagues there, IGAD, have we ever had an analysis to find out the importance of integrating family planning in emergency preparedness and response? And then to look to see how we can use family planning as one way of mitigating climate change. So I just wanted to do, if you have ever had that kind of an analysis, and would you consider to do such kind of an analysis? Because from our end, I think as FP 2030, we have seen the nexus of the two, climate change and family planning. So I just wanted to understand where we are and how we can pick that discussion. Thank you very much.
Somebody else? Yeah, welcome.
Yeah, thanks a lot for the great discussion and presentation. I'm Damaris Matoke from the Kenya Medical Research Institute. I'm a research scientist. Hearing what we're discussing and from especially the IGAD presentation, I miss out to see at what point do we utilize research data, evidence informed. I know you projected a part where, yes, climate is coming, we're going to see a lot of drought, we're going to see what forums do we have where research scientists, the medical research scientists, present data showcasing a relationship with either increase in rainfall, temperatures, with health-related issues. I know like in Kenya, where there's been a lot of flooding and rainfall, we've been seeing increase as far as malaria cases, but more so vector-borne diseases where we are having more mosquitoes, the invasive species coming along. But what forums within our African continent do we have to discuss that data output with the decisions that we are making or platforms that we are putting in place to address climate change? Thank you.
Thank you. Pre-event data are almost always available. During the event and post-event data are very limited. And I think there's an area, as our colleague from the position mentioned, that post-event data need to be collected, pooled, and I think Isaac HC can do a lot of job around here. We have somebody from this corner here.
Yeah, thank you, Chair. My name is Geshom from the Tropical Diseases Research in Zambia. My comment is actually similar to the colleague from KEMRI, because I come from a research institute. And so I was thinking, as the discussions were going on, what plans do we have as a region to improve research in climate change related diseases. Examples are many. She has mentioned some of them, but issues such as how do, for example, climate change affect disease transmission of zoonotic illnesses, but also looking at things from health systems. How can we make our health systems more resilient to climate change? Some of the solutions have been mentioned earlier, such as solar systems where necessary. But beyond that, how can we make our health systems in general more resilient and prepare our populations through community consultation? What kind of measures can we use um, through research to find out how to prepare our communities to respond to climate change? So there are many areas of research that we can do, but how do we incorporate that in our discussions as we go forward?
Thank you, dear. I think I'm sorry, I have to close down. I've been warned not to go beyond the time limit given. I think we can carry on with the discussion during our lunchtime. I'm sure this brainstorming session was an event, and lots of thinking and rethinking need to be done to make things work together. Thank you all the panelists for being with us. Thank you.
The good thing about our discussion is that we touched the real life of the people and the community. And this is why the discussion is so touching. Thank you for the presenters and the chairperson. A big round of applause for them again. Thank you so much. And now we move to sub-theme 6, reproductive, maternal, neonatal, child and adolescent health and nutrition. This is going to be chaired by Kenya in a specific way, Damaris Matoke. Madam, you're welcome, please.
Thanks a lot. I think we've had a great morning listening to climate change. And now we shift that to look at issues around reproductive, maternal, neonatal, child and adolescent health and nutrition. And to start us off, we are going to call Dr. Andrew Sulumensi from EXA, who's going to give us a presentation around the topic on protecting children from violence, regional updates, and momentum towards upcoming global ministerial conference in Colombia. Andrew, are you here?
I'm right here.
Oh, you're the one. Welcome, welcome. Thank you.
Thank you very much, Chair. So my presentation is really in two parts. The presentation is in two parts. I will start to just give a brief overview of the situation of preventing violence against children in the region. And then a colleague from the World Health Organization is going to give an update on the ministerial conference on violence against children that is coming up later in the year. We can go to, okay. The billion-dollar question is this really a problem? The world has 2 billion children. And data shows us that 1 billion of those children have been subjected to violence of one kind or the other in the past year. And that is looking at the year 2016 when this research was done. And talking specifically about physical violence, it is recorded that 1 in 4 children suffer from physical violence. The question also is, what are the lifelong consequences of violence against children? There are a myriad of them, ranging from physical, mental, and indeed other social consequences. And these cannot be overemphasized. That's why we need to talk about this vice that affects our children. Now, we can only understand the problem and devise interventions against the problem if we know what the problem is, and we have to find a way of measuring that problem. For violence against children, we carry out what are known as violence against children and youth surveys, which are nationally representative surveys of adolescents and young people aged between 13 and 24. And these surveys generate a wide range of information about violence in childhood and in young adulthood that can inform policies and programs that are aimed at intervening and preventing the vice. To date, there are 26 VACs that have been conducted, and 23 of them have been in the sub-Saharan Africa region, Southeast Asia, as well as Latin America and the Caribbean, which represents 12% of the world's children and adolescents. Quite a lot of data is generated from these surveys, and clearly we see that our region is not exempt from the problem, looking at the high rates of violence that affects children in our region. We can go to the next slide. For the EXA region, we carried out a regional landscape analysis on VAC in the year 2022, which aimed at identifying and assessing the legal, policy, and institutional and other measures that are aimed at preventing and responding to VAC. We also intended that we document what we find as well as compile recommendations in addressing the problem. Next slide. I'll quickly just list some of the findings in respect to the persisting challenges that we identified. These are deep-rooted cultural values and practices, inadequate information and on prevention mechanisms, weak enforcement on legal provisions, incoherent multi-sectoral coordination. Next slide. When there's allegation of VAC, quite often the wheels of justice are slow. There are research gaps and poor knowledge uptake, weak ICT systems and infrastructure, non-reporting and under-reporting, limited child participation in child protection. All these problems linger and they need to be addressed as we look at this problem. Next slide. But we also were able to pick up a few best practices in the region. which include policy and legal interventions. Quite a number of countries have made progress in putting in place the appropriate legal and institutional frameworks to address the problem in order to create an enabling environment. There are also interventions at community level, as well as quite a lot happening with regard to social and behavior change communication. In the Best Practices Forum that was held in 2023 February in Maseru, the health ministers of the EXA health community did raise this concern regarding violence against children in the region. And to this effect, informed by the data that has been derived from the regional studies, they passed a resolution which urges member states to advocate for the use of context-specific violence against children data to inform and drive systems-based actions within the health and other sectors, including integration of VAC survey indicators into national surveys and data collection efforts. And would like to build on that resolution that the health ministers made last year. Next slide. So a few recommendations going forward. We would like to advocate that we scale up data collection through research, regular surveys, and surveillance, strengthen the multi-sectoral coordination mechanisms as we recognize that this is a multi-sectoral problem and it needs to be dealt with as such. There's the aspect of financing, and in this regard, we need to agently cost the national action plans, which have been developed based on the data, so as to allocate adequate budget for implementing VAC interventions. And last but not the least, establish structures and processes for safe and meaningful participation by the children in VAC prevention and response, as it is said that nothing for them without them. Next slide. My last slide really just speaks to the fact that prevention of violence against children is possible. We have two examples, one from Eswatini, the other is from Kenya. The Eswatini example is the progress that has been made in addressing sexual violence against girls, as we see the comparison between the data for 2007 and 2022. And in the case of Kenya, violence of different forms affecting children from comparing the years 2020 and 2019. Nelson Mandela said that history will judge us by the difference we make in everyday lives of our children. So I hope that that will remain as a message ringing in our ears. I would like to acknowledge the support from USAID through the University Research Company. The next part is a pre-recorded message from our colleague from WHO, and I would like to ask that the IT just plays that video. IT?
Good morning. My name is Binta Sapo, and I work for WHO Regional Office for Africa. I'm a technical officer working on issues of violence against children. I am very pleased to speak to you all today on the first Global Ministerial Conference on Ending Violence Against Children that will be organized in November. As we all know, violence against children remains a major issue and in our region. And this ministerial conference is a much needed initiative to bring all the actors working together in order to reach the Sustainable Development Goals target of 2030, which is to reduce all forms of violence against children. Indeed, without really a renewed commitment and effort, we will not be reaching the Sustainable Development targets, with 1 out of 2 children still today being victim of a form of violence. Ministerial conference will take place on the 7th and 8th of November 2024 in Bogota. This event is co-hosted by the government of Colombia, Sweden, WHO and UNICEF, and the UN Secretary General's Special Envoy for Ending Violence Against Children. As the title of the event refers, this is going to be a ministerial conference with ministerial delegations of countries all over the world being invited to come to Bogota to discuss this very important issue. We are recommending, of course, and encouraging governments to bring along a multi-sectoral delegation comprised of the different departments in government that are involved in violence against children, and also bring in the allies from non-governmental sectors and NGOs to be present also, as they all are part of the response to violence against children as well. And I cannot stress enough the importance of the health sector in the response. Of course, this is multi-sectoral. The social development areas, the education sector, all have a role to play. And we really encourage delegations to reflect this multi-sectoral nature of the issue that we are trying to tackle. The ministerial conference has, of course, many objectives, and we are trying to achieve many key milestones here. The first one being having very strong commitments from government and of non-governmental organizations as well towards ending violence against children. We are aiming for commitments that are targeting strategies that are evidence-based, such as the strategies within the INSPIRE framework. Second, we are taking this opportunity of the conference to reinvigorate the Pathfinder initiative. As many of you are aware, and many of the countries present in this meeting, I'm sure, are part of the Pathfinder countries, we would like to see a new, improved version of this Pathfinder being launched at the ministerial conference. This conference also will see the creation of the first global youth-led movement on child violence prevention. This is to ensure that those who are the first victims of this situation also have a voice, and that their perspectives are included in the responses and the policies that we put in place. Of course, this being a very high-level ministerial conference, we are expecting a political declaration from governments. And last but not least, this conference will be a platform for survivors to share their expertise and also their experience. So you see, this is a very ambitious ministerial conference that we want to have impact and be inclusive. And we are reaching out to all the different actors and making sure that they're present and they have a voice and that their perspectives are included. This will be a 2-day conference, day one being devoted to more a political focus, with ministers making their national commitments, and day two having a more technical feel, where we will be discussing the solution, the evidence-based strategies to end violence against children. Throughout the 2 days, we will be, of course, showcasing the different commitments by government, but also by the different other entities that are tackling the violence against children. In addition to those 2-day conferences, we'll have some satellite events. These satellite events will be in the days leading to the conference, which are Thursday and Friday. The day 1 and day 2 are actually Thursday and Friday. So the days before, there'll be a series of satellite events that are organized by partners and different organizations that will go and deep discussions into some key thematic areas on violence against children. These could have, they could be thematic areas, but they could also be geographical issues that are put forward and discussed. And the whole objective of these satellite events is to really build and strengthen the momentum towards the actual conference. And here, just sorry, here are just a few examples of satellite events that will be taking place. This is evolving. This list is evolving as more and more organizations come forward and propose some key themes to be discussed. So if anybody in the audience would like to reflect and think about the possibility of satellite events, this is still welcome. Saying before that this ministerial is very ambitious, and indeed the inclusion of the ministerial requires much work. And there are many work streams where we look at what we can do with countries, the work of CSOs, survivors, youth. We're tapping into celebrities and media, the work of donors, and also other initiatives. All will be brought together and presented at the conference. I would just like to focus a little bit more on the work that we're doing at country level. This is mostly a collaboration between WHO and UNICEF, where we're supporting countries to conduct these, what we call national preparatory sessions. These sessions or consultations at country level that ensure that countries who come to Bogota are well prepared and make commitments that have meaning and that will be followed through. All member states, as I mentioned before, have been invited to participate in the ministerial, and all are encouraged to take steps to prepare strong commitments that they will be presenting at the ministerial. However, we are working with a little bit more focus on 30 countries globally to support them in developing very strong statements and commitments. So these selection of countries is based on what the work that has already been done in those countries, their willingness to continue as Pathfinder as well. In the African region, we have selected 11 countries with which we're working very closely. Ghana, Cote d'Ivoire, DRC, Ethiopia, Kenya, Liberia, Nigeria, Tanzania, Uganda, Zambia, and Zimbabwe. In these countries, we're working with them on developing their narrative. And as you see, we try to really have a good representation of the African region, with East Africa, West Africa, and Southern Africa being well represented. What are the objectives of this preparatory session? I think I alluded to it earlier, but it's really to capture the national story. Through these consultations, we want to make sure that we capture the progress that's been made in the countries, the gaps, and also ensuring that we highlight the key priorities of the country. And that story will allow the countries to agree on specific, concrete, and costed commitments, in fact, that will then be presented during the ministerial conference. In addition to building the story and building the pledge, we also want to take the opportunity of the National Preparatory Session to discuss the new version of Pathfinder. I'm sure a lot of you are aware of the first version of the Pathfinder, and we want to build on what has worked, what hasn't worked, to make this new Pathfinder version a much stronger version that will have impact in the years to come. New commitment that a commitment that is quantifiable, that is needs driven, hence the need to identify the true priorities of the country and that are measurable to make sure that we have a monitoring system embedded in the pledge to make sure that countries are accountable for the commitments that they make. Here are just a few examples of pledges. As mentioned, the pledges are built around the INSPIRE framework or the strategies that we know are evidence-based to reduce violence and eliminate violence against children. So this could be implementation and enforcement of laws around parent and caregiver support, response and support services, education and life skills, and others as well. You may recognize the INSPIRE framework here, and under each of these labels, you could have, countries could make a pledge. So this is just a few examples. I would really strongly invite you to visit conference website, which has many other examples and many resources that you can go through. And please do not hesitate to ask any questions. We are here to support, and we really hope that there'll be a strong presence in Bogota, that many countries in the region will be part of, and ministries of health will be part of these delegations coming to Bogota. So thank you very much for this opportunity to speak at this forum, and hope to see you soon in Bogota. Thank you very much.
Thanks a lot. Let's appreciate Binta. Right now, we are going to take a few questions, should you have any. And I know Andrew is seated alone here to respond to the questions, but I'm sure there's a great team in the midst that will support. If we have any questions towards Andrew or to Binta? Questions? Okay, yeah, we need mics around. There are a few questions here. Let's start with Mauritius.
One simple question that bothered me always on this subject: what level of violence is violence? You know, it's very important to decide that, because sometimes it can be very tricky. Can be very tricky, you know. I'm sure all of us sitting in this room must have had something in our childhood. Yeah. So I think those violences shape our destiny today, if I'm not mistaken, unless somebody don't agree with what I'm saying. So I need to request you, please define us this very simple question for me. Thank you.
Yeah, that's a great question. It's important to debunk what is violence, what level of violence is violence. So we're going to take another questions. I think we'll take 2, 3, then we get feedback from Andrew. We need a mic, some mics, 1, 2, yeah.
Thank you very much for the presentation. I think for me, my question or area of concern goes to what level are we also incorporating or thinking about training of key stakeholders in the countries as a responsive form to implementing violence against children interventions in the countries? And then going beyond that, how are we also thinking about including it into primary healthcare services, or are we even thinking about that? Thank you.
Thanks for the great question, training and inclusion in the healthcare services. Yes.
Thank you for that very interesting initiative. I never even imagined we could have a program like that. So my question is, first of all, to reinforce the initial comment from Mauritius on the definition that is being used, because I think there could be a lot of social cultural differences between countries, between continents, and the definition probably should be social cultural sensitive, but with the aim, of course, of getting to a certain level of acceptability of what should be considered as no violence against children. The other issue I wanted to find out is if there is any thinking along labor. I've seen in several countries with regards to mining that a lot of children are being pushed into mining activities. To me, that seems like a severe form of violence against children. I'm sure it could also be happening in agriculture, but I wanted to find out if there is anything that relates to labor amongst children.
Thanks. I think it's an addition to the violence. I thought when something is violent, it's violent. It's not, shouldn't be tolerated. But let's respond to those 3 questions to start with.
Thank you very much, Chair. And I admit they are very interesting questions. First disclaimer, I'm not an expert in violence against children. But having said that, I think they're important questions, and the social cultural definition of what violence really is, I guess, comes into the picture. Is Vivian around? Yes, Vivian, this is your question. Please come.
So Vivian can come. You can be taking the next question as Vivian comes to respond to it.
On the issue of training stakeholders, quite a lot is being done in the schools where teachers are being made aware of this problem and also being given skills to prevent violence against children. There are also packages that relate to parenting, an important intervention in terms of preventing violence against children. Here comes the expert to answer the difficult questions.
Good afternoon. So my name is Vivian Mangoli. I come from Kenya, and I work with the Directorate of Children's Services in the Kenyan government. What is violence against children? Interesting question. And I will answer it in the form of definition of violence first. And then once you understand that definition, then it is that violence against children. So anything that causes injury, mental injury, physical injury, sexual injury, is defined as violence. And it also includes exploitation and abuse. So when you're saying violence against children, it's all that, including maltreatment and neglect. It is all that against children. So now when the participant who asked about child labor, then we, even in the measurements of violence against children surveys, we categorize them into emotional, physical, and sexual. Then you would ask yourself, is this form of what you perceive as maltreatment on a child, where does it fall? Does it fall on the physical part? Does it affect the child emotionally? Does it affect the child sexually? And then that will help you define violence against children. So I know we like arguing that we hear you're talking about emotional violence, physical violence, and sexual violence, but where do the harmful cultural practices fall under? And I like responding by saying If it is female genital mutilation, for example, it has an effect on the physical part and also the emotional part and the reproductive system, which is the sexual part, and they may fall under that category. So I don't know if I'm answering the question.
I think you have. She's done well. I think there's a part where social culture of balance comes in, maybe that one, and also inclusion in the health system, the teaching and training.
I will answer the social cultural part. The health, I think Dr. Andrew will answer that. One of the main drivers of violence against children is the social cultural norms that we practice in Africa. And what we feel will drive this change, according to the definition that I have given, is when we employ social behavior change to the norms and values that we have normalized in Africa, all over, from the household level to the community level. I know that we know that punishing a child at the household level, at the household level is normal in some cases. Where I grew up, you have to be beaten to be somebody, but it doesn't have to be that way. So we have to work towards changing those norms and values to better bring up our children or to care very well for our children.
Thank you.
As we saw from the presentations and from this discussion, the health sector plays a major role in this. And for this reason, health workers are also being made aware of the problem and also being trained in how to address it, and also being incorporated in the primary health care, as was mentioned. Thank you very much, Chair.
Thanks a lot. Let's appreciate them. It's been an interesting one. And I think it's important for us to attend the conference that they invited us to. So without much ado, I'd like to welcome Irene Ilenga, who's going to moderate a panel looking at the FailFest using the AMREF experience. Welcome, Irene. Let's welcome her.
Good afternoon, everybody. How are you today? We're close to lunchtime. Insulin levels may have dropped a little bit, but I promise you, this is going to be a fun experience for all of us. And as you can see, with the title of our presentation today, it's Oops, Aha. Failures in Adolescent Youth Sexual Reproductive Health Program Implementation. I am going to introduce to you a knowledge management technique where we are going to talk about issues that are actually affecting us in the family planning and reproductive health sector. And we are going to engage in an exercise, and we are going to start being comfortable in being vulnerable about program implementation issues that we're facing. All right? So my name is Irina Lenga. I work for AMREF Health Africa at the Institute of Capacity Development, and we run a project called Knowledge Success, which is a consortium partnership of four organizations. That is Johns Hopkins Center for Communication and Programs, AMREF Health Africa, which is implementing in East Africa. Focus countries are Kenya, Tanzania, Uganda, and Rwanda. Although our program implementation spreads throughout USAID, FP, SRH focus countries. And we also work with FHI 360, which is the lead in family planning and reproductive health, technical assistance. And we also work with Busara. And Busara helps us engage in human-centered design in implementing our project. Our project focuses on using knowledge management as a vehicle to help family planning and reproductive health practitioners learn more, do more, and share more. Now, we did a landscaping analysis in 2019, and we discovered that many family planning and reproductive health practitioners face challenges in using knowledge, accessing knowledge, retaining knowledge, and therefore they were not learning from each other or sharing information enough. And therefore, our program was sponsored by USAID, and we've been implementing since 2019. We're in our 6th year, we're going to our 7th year, and we've learned a lot by using knowledge management practices and approaches. Now, what is knowledge? Because I'm talking about it very loosely, and it would be good if we're all on the same page. So knowledge is many things. It could be data, evidence, techniques, and practical experiences. Today, we're starting our session by talking to you about the work of Knowledge Success, which aims to help family planning and reproductive health community improve equity in health system and programs, develop localized system of continuous learning and knowledge sharing, and also optimizing resources and coordination among national, regional, and global stakeholders. As I explained, our program started in 2019, and we're going through beyond 2025. We have hubs in Asia, West Africa, East Africa, and North America. And I've already talked about the partners that we work with. We aim at helping countries and programs learn more, share more, and do more. What shall we cover today? The topic was quite interesting. Oops, aha. We're sharing failures and why sharing failures is important. We're going to become very vulnerable in how we're sharing these failures. All right. We are going to learn how to improve through failure. We are going to hear individuals, very brave individuals from regional organizations that are working in the AYSRH realm in East, Central, and Southern Africa. And they're going to share their experiences with us. And then we're going to reflect. My question to you right now, as I call upon our speakers, is, have you ever been part of something that didn't go well as you're implementing your program? It could be from an internal perspective, or it could be external influences which you did not have control over. I would like to introduce our speakers for today and call them upon the stage. And these are Lucy Murage, who is the Regional Technical Advisor, Maternal, Newborn, Adolescent Health and Nutrition International. There's a very good reason why she's coming in here today. All of you were there, or a majority of you were here, were in Lesotho last year during the launch of the AY SRH strategy on nutrition. So she's going to speak a bit about that. We have Twambirire Mwambugulu, Advocacy and Accountability and Partnership Manager for the East, Central, and Southern Africa FP 2030 Hub. They do quite a lot of engagement and advocacy for youth in FP. And we are going to call upon Gloria Changama, a program officer of East African National Network of AIDS and Health Services Organization, ANASO, who are championing the SRH bill in East Africa. Amongst us is one of our very good partner, PPDRO, Partners in Population Development, our representative from the Africa Regional Office, who is the acting executive director, called Patrick Mijira, and he's going to speak about this topic straight from a big convening as well, and we'll call upon him as we go. I would like to introduce my colleague, Colin Sotieno, to come and take us through this whole process, and then we're going to get into our engagement session. Kindly, please, scan this code, menti.com, 88174915, and this is coming to prepare us. There are a couple of questions that we are going to ask you. And the first one that I did ask is, have you been a part of program implementation and something did not go right? Please scan the menti.com, and we're going to display the results that are going to come up in a minute. Are we all there? This exercise is quite interesting because then it puts us on one panel and warms us up to the activity that we're going to implement in a few. Menti.com. The code is 88174915. 4915. Have you ever been part of something that didn't go as planned at work? I have one brave person who says no, and I really want to meet you at the end of this because I need to get to know your secrets. I'm sure you're more than 43 people in this audience. I'm giving you another 60 seconds. Menti.com, the code is 88174915. It's displayed right there at the top. 88174915. If I could get at least 60 responses, I'll be very happy. Menti.com, the code is 88174915. We're at 49. I need 10 more, then we can move. I can say 2/3 of the people who are here actually participated in this exercise, and that will be great for me. Have you ever been part of something or implementing a project that didn't go as planned? You had all your ducks in a row, but somehow it didn't go as planned. All right, 63 people, thank you. My second question to you, we go to the next slide. What is the one word you think of when you hear the word failure? Disappointment, learning, useless, insufficient, less important, incompetent, postponing, sadness, shame. We have disaster. Whoa, you guys are rough on yourself. Ignorance, pain, why, oh, why? Blunder, poor planning, bad timing, money, exams. We've got some students around here. Congratulations. And accomplishments. What will people say? All right. Pain, loss, sad. All right. We've had quite a number of people giving us their opinions, and please trust this process because as we go on with the conversations, you're going to understand why we're trying to normalize sharing this experience to learn. Collins.
Thank you so much, Irene. There's a third question as well as we are settling into this. And the question we're asking was this: what comes to mind when you think of the word? Why do you think it's important for us to learn from our failure and to share them? So it's what do you think? Why do you think it's important for us to learn from our failures and to also share about our failures? So there are some answers. They look for solutions and to share lessons learned so that we get a bird's eye view of the failures and get new ideas next. So we can improve strategies. And thank you for all these responses. And you can keep on typing them in there. As we can see from the screen, folks are still thinking as we get to segue into just a lead into the conversations we are going to have. So just a quick reminder, my name is Colin Sotieno. I'm also part of the Knowledge Success team. And when you're talking about failures and failures or mistakes, it's important to note that it's a spectrum. Okay, there's a range from things that are predictable, what you could foresee when you're starting your interventions, when you're thinking about the change you want, and of course there are those that are unpredictable. So we are conscious about that. But what's important is across the spectrum, we are very intentional in identifying these and then learning from them. And that's what some of the conversations and the sentiments that this panel is actually going to touch on, that there are some things that are predictable or preventable, if you call them. There were some that were right in the middle there as unavoidable, of course, and at the end of the day, it's what then informs us along this way. Next, please. So Irene talked about this, that we want to encourage a culture of sharing, but then specifically in that is normalize the aspect of sharing failures, because then they do inform even how we are thinking about policies and actions we want that will define the change you want to have, okay? In this process, we said we also learned as a project And we agree that we find that sharing failures is hard, okay? And people where we started this process actually saying a couple of reasons. Either they are new in their career and they'll be thought less of, they don't want to relive the experience. They think, one interesting one is they can't find time to share these failures. And that's why, even for us in the conference of this platform of best practices forum, we are using an approach of looking at our lessons and things we've learned along the interventions around AYSRH from the perspective of failures, okay? So why it's important? Draw on our experiences, because a lot of the knowledge is tacit knowledge. A lot of our knowledge as individuals, as human beings, as people in the space of family planning, reproductive health, or people in the space of development, it's tacit knowledge in our heads, and it's in our experiences. And to also normalize sharing what works and what doesn't. And from the previous session, this statement will actually ring the bell in there, that it's about sharing what works and what's not working. But then lastly, talk about making the unpredictable predictable. And someone once in a conversation with me said, to the best extent possible in our human beings. And that is why it's important to share our failures, okay? So we are approaching this with in a format we're calling curious questions. So they're not meant to help problem solve. But they actually help to actually discuss it's almost what the individuals could do different. And they help us as practitioners, as policymakers, as advocates, to better understand our own failure, to learn from it, and apply it in the future situations. So ladies and gentlemen, I want to throw it to this panel of individuals up front here, who we say they're bold enough to actually share with us the experiences of their failures. And they're going to look at it from two specific things. One, on adolescent youth sexual reproductive health interventions in the region, but then also at a conversation from around the adolescent nutritional intervention that exists in the region. And we're going to look at this from different aspects. So we have aspects of policy implementation, we have aspects of advocacy, and here we're talking about the education, the stakeholder agency, collaborations. We're looking at from the aspect of program implementation and sustainability. Okay, and also looking at aspects of integration, when we're talking about how we implement our program and how we integrate our concepts into the various health interventions. So over to Irene.
Thank you very much. We are celebrating 50 years in leadership, and we're very happy that the EXA community has actually been on the forefront of promoting adolescents, youth, adolescents and young people, especially with sexual reproductive health initiatives. It has consistently been priority in resolutions that have been brought out. We have resolutions that are looking at SRH needs for the adolescents and young people in the region. We have considerations for people with disabilities. We actually, within the region, there's been standard packages, practice packages that have been developed by expanding access to family planning, maternal, newborn child, and adolescent health services. And just recently, that is in 2023, there was the adolescent nutrition and advocacy strategy that was set aside. Now, we have 3 speakers, and all of them are working within the AYSRH space. And I would like to ask Glory to share with us about the SRH bill. All of us are aware of it. It focuses and targets adolescents, youth, adolescents and young people. So what exactly makes it meaningful for you to share about this experience in implementing the SRH bill, and what has been your experience, and what thing have you experienced in trying to get it out there since 2019, if I'm not wrong, or 2017? And why are we stuck? It's important, but why are we stuck?
Yeah, thank you so much, Irene. As Irene mentioned, my name is Glory Chagama, and I work with an organization called IANASO. I would like to share the journey that IANASO did since 2017, when we started to advocate for the policy development and for the EAC Sexual Reproductive Health and Rights Bill, the then EAC Sexual Reproductive Health and Rights Bill. So this bill started in 2017, and it was a private members bill, which was introduced by the third IALA in the EAC Parliament. And basically, the purpose of the bill is to support or to make sure that the EAC communities access sexual reproductive health and rights services and commodities. So in 2017, the bill was introduced, and unfortunately, there was a lot of contentious issues that were raised, which led the bill not to progress, and the third IALA term ended. So it was just like that. And when the term is ended, then the next, which was the fourth IALA, took over. And when it took over, it has to restart again the processes, because now this is the bill and there are processes that are to be followed. So the fourth IALA the bill was reintroduced, but during that time, it took a lot of scrutinization, a lot of consultations, and redrafting of the bill. So we got a mover of the bill, who was Honorable Mukulia from South Sudan, who took the courage and again reintroduced the bill in the House. So the House took into consideration, and then the processes there started. So we started with consultations, we started with doing partner state consultations, we did community consultations. We also tried to capacitate the members of parliament who were the owner of the bill, the GPC committee. So during that time, it was not easy. We had a lot of backflash. The anti-rights movement was there because, as we understand, sexual reproductive health has a lot of contentious issues, which really brought challenge to us as we were trying to move forward. Other issues that we faced were issues of financing. We didn't have enough finances. We all know that dealing with policymakers needs a lot of money, needs finances. So we didn't have that. So to us, it was also one of the hindrances, made us difficult to move forward. We want to do capacity building with the GPC, with the IALA members, but we don't have resources. How can we move forward? That was, on our side, it was a failure because we didn't have enough resources, or the resources that we had were not available to support that specific cause, because we know the need. You invite a member of parliament, they need a certain, you have to pay them sitting allowances, you have to pay them per diem. It was a lot for us. So we have to coordinate ourselves like civil society to beg and ask, because we don't have that funding. Another thing that we thought brought us back is, of course, we managed that because we also got some partners who helped us into that. So the bill progressed well. It went into even the public hearing and again the second reading. But when we are about the bill to go now for the third reading, then to be represented or to be passed, now the fourth assembly, the time ended. Yeah, so when the time ended, we didn't have nothing else to do, because that is constitutional. And when now the fifth assembly took, we have to restart again the processes. So you can imagine. And for us, I wanted really to present this. To us, at some point, it is a failure, but again, it is a lesson learned. And I think going forward, I will explain more why I say that. But as I speak, the bill has been again reintroduced with the fifth IALA, and we are planning to restart again the consultations and other constitutional processes. Thank you.
So thank you very much for sharing that. And I think there's even a bigger challenge, and she will speak to it in our second round of conversations around speaking candidly about what is actually happening and what is blocking these things from moving forward. we have 2 new babies in East Africa. So we have to do public hearings yet again and do everything. So it's a cyclical mess. Next is Twambi, and he's an advocacy and engagement manager, FP 2030. They do have a very big focus on adolescents and youth, especially when we're looking at family planning and reproductive health. I would like him to share his experience about the thing that he is doing in program implementation that doesn't seem to be moving forward or poses a challenge to addressing young people's needs for FP.
Thank you very much, Helen. It's very interesting and also a very difficult question, you know, asking someone to talk about their failures in the spotlight. But it's a learning process, so I think it's also good. So, you know, FP 2030 started as a global movement in 2012, where we had the FP 2020, and then now we're in the FP 2030. So when we were setting up FP 2020, to kind of like advocate for family planning across the globe. So we started up with a regional secretariat, and then you have a regional secretariat maybe based in the Washington DC, and then you want to advocate in other regions, all right? So that was one of the things which I think was a challenge in terms of now strategic movement in terms of political mobilization. And then moving on to FP 2030, we have got structures that we work with, all right? We have got an adolescent and youth SRH strategy to advocate for family planning in across the globe. But now I'm talking an experience of the East and Southern Africa. So for us to advocate that, learning from the global structure, we have now moved into a decentralization structure where we have regional hubs to kind of like champion family planning in regions. And I myself and my director here, Dr. Sheila, who is also present here, we are managing the East and Southern Africa hub. So we are kind of like now responsible for a single region, and we have decentralized from the global management. And again, within the decentralized framework, we have what we call a focal point structure. So the focal point structure has got a youth focal point, the government focal point, and the civil society focal point, and the youth focal point. So these are the people that we rely on. My point is that we don't have a physical presence in a country. We have to work on the trust of partnerships and collaboration, because FP 2030 is based on partnerships and collaboration. Now, you would have country A, for instance, for example's sake, you would have Malawi, where you have got an active focal point structure, able to advocate, able to talk to the government, and then you go to country X in East Africa, maybe which is Rwanda, you have a focal point structure that is not very active. So that gives us a challenge in terms of political will mobilization, because you have to work with a structure, and that structure is also responsible for implementation of other adolescents and youth empowerment programs in family planning. So you are based in the regional hub, and you have to think about Malawi, and you have got a structure that you want to work with, and then that structure may not prioritize your family planning issue. So to us, that is also a programming failure. But then once we realize in terms of how the weaknesses of the focal point structures, we have moved a step ahead to kind of like to see how do we now link the focal point structure to the government structures that are already there. For instance, the technical working groups. How do we align the focal point structure, which is comprising of the government National Family Planning Coordinator, a donor representative, could be UNFPA or USIT, and then it could be an active civil society organization within the country, and then we have a youth focal point who is coming from a youth-led civil society organization. So how do we align all these people to be part of the broader technical working group in order to advocate for family planning within the country and improve SRH needs for the youth? So we have been working with such a structure, providing capacity strengthening and linkages. But again, within the process of learning, we have also learned that some of the members within the focal point structure do not have a political connection within the system, because mobilizing for domestic resources or mobilizing for family planning usages, you need to have a strong advocacy skill and a strong connection. So those are the things that we are learning within family planning, to say, how do we now cross-lane between an active focal point structure versus a focal point structure that is not active? And then how do we now bring in the political will into this focal point political structure? So as part of our learning, we do what we call cross-learning forums where we would have focal points from East and Southern Africa, bring them together. Have Malawi share their experiences with Zambia in terms of how Zambia is advocating for family planning for the young people in their countries. So it has been a transition of moving from a global position to a decentralized structure, and then engaging with focal point structures, and then within the focal point structures, creating linkages within country structures and systems that are already there, just for us to penetrate the political space where we can now be able to negotiate. So our key lesson and our key failure is that when you want to coordinate a global movement, you need a lot of political mobilization, a lot of structural engagement, and also a presence, a continuous presence in order to create a continuous discussion and deliberation. So it has been a process of learning and improving within the same process as well. But there's a lot of more to improve, because I've said there are other countries that are not performing well in terms of the structural focal point structure than others. And again, the issue of family planning for young people, it's a very contentious issue. The way you'd have the discussion in East Africa is very different the way you have the discussion in Southern Africa. So that we are also learning to say, how do we now position our messages within East and Southern Africa, within ourselves as FP 2030? Do we go with a general knowledge, a general message? So our advocacy message has been issue specific. Where we were coming from, we are advocating as a global spectrum, but now we're saying, let's decentralize the messages, let's contextualize. The same thing with domestic resource mobilization for family planning for young people. The countries are at different levels, all right? So our message also at first was, let's mobilize resources, all right? But now we realize that is a failure. This domestic resource mobilization now needs to go beyond financial analysis, just to say there's no money in family planning. We need to look at where the money will come from and where will it go. So learning our advocacy failures in terms of how we need to mobilize for resources, we have now learned that we need to partner with institutions that are very public expenditure analysis and tracking, institutions that know how to move resources, and again, work with the right departments within a country context to say, how do we know that, where is the funding stuck? All right, because we have got governments allocating resources in the budget, but then when it comes to actual implementation, the resources are not driven or not given. So our advocacy has now moved beyond just doing a scooping to actually now tracing the monies from point A to point B, and how do we bring in the investment of private sectors into family planning. So it has been a journey that we are learning and will continue to learn.
Thank you. From global to localization and to further digging into the local contexts to provide AYSRH services, looking at connections and links. Our third speaker from Nutrition International has played a central point in the partnership with EXA-HC and the AYSRH strategy for nutrition. Please share with us what your challenges are and what you've learned in the last 12 plus months.
Thank you, Irene. So as Irene says, I work with the Nutrition International, and I am supporting the maternal, newborn, and adolescent health programs. And we're working very closely with EXA, especially to move forward the agenda to advocate for adolescent nutrition within the region. Out of a ministerial deliberation, EXA was mandated to come up with an adolescent nutrition advocacy strategy. And this came from the realization that, there's a lot of work going on in nutrition in most of our member states, but a lot of this work actually focuses on children under 5 and on maternal nutrition. And when you think about nutrition really, if you're going to move the needle on some of the key public health issues we are seeing in the region, things like anemia, especially among women of reproductive age, and also malnutrition, not only for under 5s, but now, and you've seen even in the data being presented, the issue of overweight and obesity, which actually drives a lot of the NCDs that we are seeing. And so there was that realization that there is this group of adolescents that's being jumped, not only in policies, but in programming. And hence, we came in to do a landscape, and we saw that in most of the countries within the EXA region, there is either no policy on adolescent nutrition, or where it exists and where programs exist, they are very disjointed. and they are also only, being implemented at a very small scale. And so these advocacy strategies actually focusing on several components of adolescent nutrition. One is actually looking at multi-sectoral coordination and collaboration to ensure that we are coordinated in the way that we are not only designing our programs, but also in the types of policies we are bringing on board. And these policies, again, number two is that they need to be based on evidence. And so what evidence do we have of what works in adolescent nutrition? And so the policies and programs need to be, anchored in evidence. And WHO has come up with 8 actions that countries can focus on when it comes to adolescent nutrition. And so we are hoping that, even as we support countries, then we are anchoring them on that evidence. And the other one is actually to ensure that, then using these small interventions that are being implemented in different countries can actually be taken to scale. And taking this to scale will require a lot of not only multi-sectoral collaboration, but integration. Because as we know, finances, and it's been mentioned before, is a major setback when it comes to scaling up programs. So how can we ensure that, we are looking at what is already being done and then integrate nutrition in those programs, like SRHR, for example, which is being implemented not only at the health facility, but especially at the school platform where we find a lot of these adolescents. How can we ensure that we are not doing silo programming, and we are ensuring that we are, being more efficient and effective in implementing some of these things that can be bundled together to ensure that we have a greater impact at a smaller cost. And the last thing I want to say is that this strategy is actually meant to be used as an advocacy document to governments, and it provides, some very good guidance on what governments can focus on to ensure that we are moving the needle on some of these issues like anemia, and overweight and obesity, which is driving a lot of maternal mortality that we are seeing, and progressing this cycle of malnutrition, not only in children under 5, but also, among adolescents, and later on when these young people then decide to become mothers. So it's really looking at that continuum, just ensuring we are not focusing on only the first 1,000 days, but then we also look at the next 7,000 days that actually are the reason a lot of the public health issues we are seeing actually present. Thank you.
So I'll start with you with my question as I go back to in reverse to our presenters. The strategy was launched last year, and you've just said that adolescents and young people are the group that, when it comes to nutrition, the consideration is not priority because there are other things that are being pushed to them, but it's still an important agenda within EXA-HC. Have you gotten pushback as to implementation or even programming around AY, the adolescent and young people on nutrition? And are there countries that are doing better than the others? And if they're doing better than the others, what advice do you have for the others who probably are slower in progressing in terms of adapting? What is the advice?
Yeah, thank you, Erin. I think the strategy was actually launched last year in March, so it's barely just a year since the launch. EXA Secretariat has been actually disseminating and socializing this strategy among the member states, and so we are still at that stage of socializing and raising that awareness and knowledge on the importance of this issue. And we are hoping that, well, we have succeeded in doing that in many countries. We are yet to finalize that dissemination. If I'm to look at, programming that has so far gone on within the region on this area, there are certain countries that have done well and others that haven't. Those that have done well are those that have integrated adolescent nutrition within their national action plans and development agendas. And those that are still doing very small scale work, then we are actually seeing the the ripple effect in some of the statistics that we've seen today, especially on overweight and obesity. It means that there is very little that actually has happened. Policy-wise, many countries already have policies in place. Where we are seeing a big issue is actually in then moving those policies into tangible programs that can be scaled up to ensure that there is impact at scale. So that is really the main challenge in most of the countries. And so my appeal really is to look at the evidence that you already have that is showing you what is happening, to the older adolescent, your NCD data, your anemia data, that actually tells you whether or not, there is much that is happening at country level. And the truth is that in Africa, I would say we have failed in reducing our anemia levels among women of reproductive age. We have also failed because we are seeing an increasing trend of overweight and obesity actually across all our countries within the region, which is actually a time bomb, because then the effect of that will be seen in years to come.
Thank you so much. I will address Gloria with this question because it's been, 2016 to 2024. That's quite a long relationship with the SRH bill and also with your SHARP project dealing with young people who will be affected by these results. What has made you the wiser with this experience?
Yeah, thank you, Irene. For me, I can say that one thing that have been a lesson for us is to have a proper strategic partnership. We need to have very good strategic partnership going forward, because as we want to share or to express why we need this bill to be passed, we need to have evidence, we need to have data, we need to have proper communication when we are communicating with the decision makers. Before, as we were preparing our messages, what we did, we were just sharing general messages rather than unpacking them to see which messages will be good for communities, which messages should go to the decision makers, and which messages should go to other stakeholders. So to me, this has been a wiser message to all of us. Another thing is on funding. We need funding. Honestly, pushing the police agenda is not an easy task. It needs a lot of resources, both financially, both human resource, because you need to have different expertise in the house. You need to have public health practitioners. You need to have uh, those who knows well about law. You need to have research institution that can be able to provide data when we are presenting. So to me, I thought that it's wiser that I share that when we are dealing with policymakers, we need to prepare well. Again, another thing, what it's something I've learned, that policy development is not a short-term thing. It's a long-term. It needs patience. It needs commitment. So with all these, I believe that through the journey since 2017 up to now, there are a lot of commitment that we have putting in terms of resources, in terms of time, resources in terms of money, resources in terms of time. And at some point, partners are tired. Sometimes you see you are even calling for a meeting, people are not showing up because they feel like we are called again to that activity which is not materializing. So it's a real need to be persistent, it needs to be committed, and it needs also to identify the right champions, even within the members of parliament. How can we make sure that we equip them with the proper knowledge, we equip them with the proper information? Again, with the communities, how can we, when we go to address these issues, they also hear experience from communities themselves. So I thought it would be wiser I share with colleagues, but again, I know we are going to have time. Also, they can share with us some of the issues. For instance, I know colleagues from the Southern Africa region. For them, they have a bit progressed than the East Africa community, and we would really want also to learn from them. So thank you so much, Irene.
Thank you so much, Gloria. And our final question, what has made you the wiser? You shared about the reconstruction of the implementation process from EPI 2020 to EPI 2030 and your actual structure right now actually working for you and for the target audiences. What else would you like to share with us, especially when it comes to advocacy on AYSRH in the region?
Thank you very much. One important thing is creating space for the youth themselves. And now, creating space for the youth themselves does not mean just putting them there on the spotlight. Our AY strategy, the Adolescent and Youth Engagement Strategy by FP 2030, the vision is to make sure that the youth become self-advocates. So we are focusing on strengthening capacity of the young people in terms of policy making and strategic engagement. One of the things we have done recently is we have engaged the youth in what we call smart advocacy. So we are doing beyond ordinary things. We are now looking into what are the practical elements and what are the platforms for making decisions. So we put together young people from different countries, bring together the youth, and then teach them about budget analysis, financial scooping, and political engagement through what we are calling the smart advocacy. And the smart advocacy also includes the DRM component. Where do they go and knock to advocate for resources? And again, now that we have decentralized, where we have reduced delayed decision making, and now we have gone into the country where we have now a focal point structure which is able to navigate and engage the youth. What we need to do right now is to now increasing the capacity, or strengthening the capacity of the focal point structure, now to make them get themselves a seat at that decision-making level. Do we begin to negotiate with the government to say, do we need a director or a PS or a minister to sit in the focal point structure? Because right now, the focal point structure is selected by the government itself. But we still have a negotiating deal because of our experience to say, learning from Zambia, we have seen where we have got a focal point structure that is not highly here, cannot lobby for things. And then the youth agenda is not brought forward. So our next level is also now to strengthen the focal point structure in terms of how does it do political engagement at that higher level there. Thank you.
Thank you so much. And now I turn to you. Having heard these brave people talk about the challenges they're having, calling them failures for what they are, let's call a spade and not a big spoon, and also the lessons that they have shared. How can we normalize sharing this failure so that we can learn from them and avoid the pitfalls in programming and implementation in the future? So, how did it feel to hear this story? Do you relate with them? By show of hands. Oh, very few. Man, you're going to have lunch. Just stretch it a little bit further so that I can see there was some impact in using this approach. All right. So you're not alone, and there are lessons that can be learned from here, and you're free to actually contact them. But then I'd give the mic to one more person, and that is Patrick Majira, to share with us about AYSRH, especially in the ARN network. Patrick, if you raise your hand, the mic will come to you. Can someone please take the mic on the farthest end on that side? I give you 2 minutes. And then if anyone has a question, maybe lift up your hand and we'd be able to, or an experience, a very short one, and we'll be able to let you speak.
Thank you very much, Irene. My name is Patrick Mujigwa, and I work as the Acting Regional Director for Partners in Population Development, Africa Regional Office. It's based in Kampala. So I arrived here immediately after concluding a meeting of the Eastern African Productive Health Network that was organized last week in Dar es Salaam.
And this is a network that was formed on the fringes of the ICPD in 1994, basically to promote advocacy around accelerated implementation of the ICPD agenda. But the scope of this network has since expanded and now looks at the advocacy for implementation of the various commitments, protocols, frameworks that countries have signed on, whether at the UN level, the Africa regional level, and also some roadmaps at country level. Now, this meeting was organized and the themes around the accelerating the gains and closing the gaps towards achieving universal health coverage. Now, one of the themes for this meeting was around the same subject matter that this panel has been organized. And what I took from the meeting is that actually the historical challenges, historical reasons that have constrained service delivery are still persistent. And I don't know whether the strategies that we have developed and deployed are not working for us, whether we need to have a reflection on how to do things differently. Because clearly, of course, there were a number of challenges that were varying from country to country, but there are some challenges that were commonplace and were kept on coming and repeated by a number of countries that were in attendance. Some of these include issues around human resources for health. Looking at numbers, the human resources not being adequate numbers, not having the requisite skills, but also looking at the perceptions and attitudes of the health workers towards providing these services. Another issue was around and I'll not be expounding a lot on this because I've lived with these factors. We know what the history, the things behind all these factors. Another factor was to do with inadequate financing for procurement of supplies and commodities. There was also an issue of dependence on donor funding, which funding sometimes is not predictable and not reliable. And even when it comes, it is tailored towards other priorities. On the whole, you can hear about sexual productive services, but when you dive inside the details of what they are going to be funding, they are completely different priorities. There was another issue of course, misconceptions and negative beliefs toward these services, which kept on coming. An issue of faith-based organization-owned facilities and the attendant perceptions they have towards these services, which also constrained service delivery. There was also an issue of programs being implemented vertically. They are not integrated, they are not coordinated, and therefore you cannot easily track what's happening in the country. But they also pointed out an issue of advocacy, which has failed to be sustained, mainly because of lack of resources. So I'm pointing out these challenges. They are still with us. They have been historical and they still continue coming. So I think we need to reflect and see how else can we address some of the challenges that keep on coming. Of course, you've mentioned this SRH bill, even when it is passed and it is a law, for as long as you are still living with these challenges, its implementation will still be questionable. So I want to put it to you to see how we reflect on this and other things that are coming on board. Thank you.
Thank you so much. Of course, we didn't come to give you answers to many problems, but we came to share with us. So what have we learned? Words we use to refer to failures matter. It makes it easier when you use softer words to talk about the challenge that you're having or the issues that are coming up. Offering advice helps people confront their failures. And finally, the environment of sharing matters. It took a lot of talks with these individuals to actually come to sit in this panel and share with you what the challenges they're facing. And we hope that you will be able to practice this in your different platforms. And we figured out with time, because this is not the first Fail Fest that we have done, that people feel most comfortable when they share among their peers because the problems and the challenges they're having are usually very similar. It's vocalizing it and being candid about it that is usually the issue. So as we started, it's an oops, aha moment where you're thinking, oh, yeah, this I have gone through before, and they seem to be having a plan of executing a course correction of some sorts. So thank you so much for giving us this opportunity. From the Knowledge Success Project, these are our contacts. If you would like us to facilitate any knowledge management interventions for you, you're very much welcome. Thank you.
Thanks a lot, Irene and the team. Let's appreciate them one more time. They have done an amazing job. Really, a lot of learning there and many other activities that are expected. I think that has been a great session. Don't you agree? One more time. Yeah, thanks a lot. And I think it's time for lunch. And I'd like to welcome the team, the secretariat, to make some announcement. It's lunchtime, don't worry. There's no session. So, welcome.
That was beautiful. May we have a round of applause for everyone who was here with the chairperson. Chairperson said we need to go for lunch. Why should we have lunch this early? Yeah, it is still early, right? Yeah? Yeah? Lunch is lunch, whether it is early or it is late, right? Well, this is beautiful. Yesterday we were talking about time. Today we are talking about time in the opposite way. Let me ask you for your passions for about the next 10 to 15 minutes. We can have a very short presentation here, and then we'll go for lunch. That will be around the same time we normally have lunch, almost 13:30 or something. The presentation will be on the development of AO Alliance, COSEXA guidelines and standards for trauma and injuries for low and middle income countries in sub-Saharan Africa. So may I welcome the presenter here, Dr. Claude Martin, who will be talking about that. A round of applause for Dr. Martin.
Thank you very much. We're going to change gears a little bit and talk about injuries and trauma. And if I had a little bit more time, I'd try to make the case that there's 32% more people that die of injuries worldwide than of the combined 3 communicable diseases of TB, malaria, and HIV/AIDS. But I'm not going to do that because I don't have the time, and I'm probably the only thing that's standing between you and lunch right now. I have no disclosures other than I'm a trauma and orthopedic surgeon. I am French Canadian from a very small town near Montreal in Quebec, and I had no financial conflicts of interest whatsoever with regards to this conference. So we could ask the question, do guidelines, clinical guidelines improve patient care? But I'm going to concentrate on fractures because this is what our particular foundation in collaboration with COSEXA has been trying to do over the last year. And the answer is yes, but there's a caveat. If they make sense, because people won't follow anything that doesn't make sense, and they're easy to be followed and implemented. So we have to remember these 2 things. Today, I don't have time to go through the shopping list, but we're going to define what a clinical guideline is. We're going to see how we chose the topics in sub-Saharan Africa. We have to see how do we use them and how do we write them. The last 3 are my hope that we'll be able to work with like-minded organizations like COSEXA to be able to implement them, measure them, and adapt them. So a guideline's pretty simple. It's best practice. It's aspirational of trying to do the best thing based on evidence-based medicine. It's a recommendation. It's a standardized activity, but it's not rules. Okay, we have to remember that. It's not necessary per se. We polled our entire faculty base in sub-Saharan Africa, and we asked them, what's keeping you up at night? What's costing you the most? And we chose, based on that, 3 that we felt we could tackle within a certain amount of time. So for governments, it's what's causing them the most cost, what's the most expensive. For doctors and surgeons, it's what's keep them up at night, and what's causing mainly probably the most complications. Why do we need them? Well, you need them to have a standardized method of treating patients for better patient outcomes. You also need them to be able to, what I call, herd the cats, which means that not everyone is going out on their own path to treat a particular diagnosis. So if we look at closed ankle fractures, there should be really one simple or single algorithm to treat this particular common fracture in sub-Saharan Africa. You also want to have some auditable pathways or auditable steps along that clinical guideline so that you can audit, measure, and benchmark against best practices so that doctors can go back and look at how am I doing against the rest of my colleagues, either in a country or in a region. You know, when I was growing up a long time ago, I graduated from medical school about 40 years ago this year. So it just shows you how old I am. And when I was going through my orthopedic residency program in Toronto, we would ask questions to our bosses and say, well, why are we doing this like this? Why are we not allowing patients to wait there after surgery? And say, well, that's because we've always done it like this. And that's dangerous. That is extremely dangerous. And we need to change that dogma, not just the orthopedic dogma, because we have a lot of orthopedic dogma. We need to follow patients up at 2 weeks, 6 weeks, 3 months, and a year. We need to take x-rays at 2 weeks, 3 weeks, 4 weeks, 6 weeks, 3 months, and 3 years. You don't need to do that. We need to change that dogma. And this is what these clinical guidelines will try to do. Hip fractures way back in the early 2000s were a huge problem. It became a huge problem. And you're about to have this problem in sub-Saharan Africa because your population is aging. We didn't know what to do. Do we operate for them right away? Do we wait 24 hours? Do we optimize their medical conditions before we take them to surgery? How long do we keep them in the hospital? Do we give them antibiotics before or after, etc.? We had no idea what we were doing. So the United Kingdom tackled this with some standardized guidelines. They set out to set standards. They set out to set some pathways to be able to follow, but not only to be able to follow them, but to audit them, okay? And then you would be able to benchmark your own performance, the hospital performance, against the best practices. If you look at what's available when you're developing a clinical guideline, there's a whole bunch of stuff out there, especially in the orthopedic literature. The problem is these quote unquote guidelines are 50 pages plus. They say they're based on evidence-based medicine, but 95% of the questions can't be answered based on that data. And you have no idea where you're going. So it's quite difficult to base it on the existing literature. So with the collaboration of the British Orthopedic Association, and this is extremely important, that you have the collaboration of your national medical or surgical associations, they set out to develop a one A4 page clinical guidelines for many of the most common traumatic injuries fractures that are keeping them up at night and costing them a lot of money in the United Kingdom. They now have 15 standards. They've published extensively. They've audited these standards, and they work. Not only that, but they've recognized worldwide. So for hip fractures, they now have a standardized pathway, preoperative consultation, optimization. They've decided on what the time to surgery is within 48 hours. They've decided what surgical procedures, including implants, are the most important and cost-effective ones to use. You don't need the very, very fancy implants. The old stuff still works quite well. And then physiotherapy, rehabilitation, and fall prevention and bone health needs to follow that. And to me, this is the most striking feature, is after implementation of this particular guideline, this is something that you can sell to your governments, your ministers of health. The mortality rate fell by 40%. That's measurable, and that's really impactful. Now, in sub-Saharan Africa, we took a few shortcuts because we don't have the money that the British Orthopedic Association has, and we don't have the breadth of development that we could do. But we do have COSEXA. We do have other partners. So over the course of about 2 days, we gathered about 20 trauma and orthopedic surgeons from COSEXA countries, as well as the West African College of Surgeons, the Ghana College of Physicians and Surgeons, and the Ethiopian Society of Orthopedics and Traumatology. And you see one representative from your own country in Tanzania, and the COSEXA CEO, Mrs. Stella Itingu, was also part of this group. We locked everyone up in a room for 2 days. We gave them 3 diagnoses because these were the most common ones keeping them up at night. Closed femoral shaft fractures, a huge problem now with all these motorcycles running around. Closed ankle fractures, same thing, and open tibia shaft fractures. And over the course of 2 days, the folks came up with a 1-page A4 clinical guideline for these 3 clinical diagnoses with anywhere from 13 to 17 auditable steps that can actually be measured. Now, I highlight the most important ones. For femoral fractures, no more traction. Need to have surgery, a rod placed into the tube of the bone, and it needs to be done within 5 days of the patient presenting to the institution that will perform the surgery. For closed ankle fractures, if they're stable, a cast. If they're unstable, surgery as soon as possible. And for open tibia shaft fractures, which are devastating injuries, no more primary amputations. There needs to be at least a consultation with 2 senior surgeons that that's the way to go. Now we're at the stage of implementation, okay? And this is the extensive work that we have to do. We're going to pick a few pilot hospitals and incentivize the surgeons to use them. And we'll have to see about how we use them in sub-Saharan Africa, and then how do we adapt them and rewrite some of the things that are not working so well. So my take-home messages are quite simple, is that clinical guidelines that are developed by African surgeons to take care of African problems do work, okay? They provide a standardized way with some flexibility to take care of these 3 common fracture diagnoses in sub-Saharan Africa. They save money, and that's a powerful argument to make to the ministers of health and also the ministers of finance, because the ministers of health do not work independently from human resources, finance, road and safety, police, transportation, etc. We have a second clinical guidelines summit in about 2 weeks now in Addis Ababa, Ethiopia. Again, there'll be 20 trauma and orthopedic surgeons from sub-Saharan Africa. We've extended it to include some more countries from West Africa and the French-speaking African countries. And we're going to tackle these next 3 diagnoses that have been voted upon by sub-Saharan African surgeons. Adult proximal femoral hip fractures, adult distal radius fractures, as well as pediatric elbow fractures around the distal humerus. Thank you very much for your attention.
Reading from your faces, I can see we have at least 2 questions. We can allow that. Yes, one from Mauritius and another hand at the back. So Dr. Martin, you can take the question.
Thank you for the opportunity. Our present health minister, when he joined office, he wanted to introduce clinical guidelines for the whole of Mauritius. Writing the guideline was another headache. Getting so many people, doctors in Mauritius are coming from all over the world. And to put them together to come to a consensus to write guideline is another headache. Again, we took up all the international guideline to put something for our thing. And every department was given so many topics to write and big thing volume came up. My question to you is, when we started implementing the scenario, it was just another difficult scenario. Until date, the number 5, 6, 7 that you mentioned, we're still stuck at that point. So probably listening from you, our approach was somewhere wrong. As I could hear that you have to focus on 1 or 2 key subjects that make the most economical scenarios. And probably you can be of help to us somewhere to help us to execute this plan. Thank you.
Thank you very much for the question. You cannot take an international guideline or a guideline that's been developed in a high-income country like the UK or the United States or Canada for that matter, take the guideline as it is and transpose it to a low middle income country. And that's not what we did. We took the guideline from the UK as a building block to not reinvent the wheel, because a lot of work had been done in terms of the evidence-based medicine and what worked. With the consultation from the surgeons from LMICs who have to buy into this, and we started with COSEXA country because of the collaboration that we have with COSEXA. We came up with this guidelines for 3 diagnoses that are adapted to LMICs. Now, you can't shove this down people's throats, especially doctors or surgeons for that matter, from the Ministry of Health. It won't work. You have to go through the professional medical association. So in this case, it'll be the Zimbabwe Orthopedic Association. It'll be the Zambia Orthopedic Association. It'll be the Ethiopian Society of Orthopedics and Traumatology. It will be all of these trauma and orthopedic societies where you'll do some sensitization. They will adapt them. COSEXA has already adopted them at their committees. So they have the COSEXA brand. Ms. Itungu is bringing this up to this forum here for you as a community to endorse them as well. Then you pick a few hospitals within each country to implement them. But you have to incentivize the doctors in some way, not money, because that doesn't work, but there are other ways to incentivize doctors. Hospital administrators are extremely important to have a buy-in to this. And then you see if it works or not. And then you enroll some residents and research students to be able to do the research to check on whether the surgeons are meeting the auditable steps. What's their percentage? Now, in the UK, this is all gathered automatically because the hospitals have no choice. Now, the Ministry of Health has shoved it down the doctors' throats, or else they don't get paid. Okay, or else they don't get paid. But it took a while, the 20 years to get to that step. So I'm not expecting that we're going to make inroads tomorrow or next year. but we have to start somewhere. And I think that this is the future of at least trauma and injury care for me in sub-Saharan Africa. Thank you. There was one more question, I think. Yes.
Yes, we have two questions. I would love if we get both, and then you will answer them.
Yeah, also
together.
just to appreciate the presentation, and I think you have picked a good area. The hospital, I come from Kenya, and the hospital, the Kenyatta National Hospital, where I am, the orthopedic wards is one of the ones with the longest, time of stay in the hospital, and consumes a lot of money.
And there's no reason for that.
And it's always a headache, to the hospital management. On the guidelines, the approach of the hospital is the hospital would like its own guidelines rather than the ones that are pushed from outside. So standardization and accepting is also a challenge. But when you develop the guidelines through the hospital, just agreeing on the format itself and the standard to follow, because there are literally tens and hundreds of formats. There will be the WHO format, the American formats, the local associations formats, marrying all these ones and in an A4 format like you have, I think it's nice, it's a challenge, and it would be nice to engage and see whether this might work also for some of our hospitals. Thank you.
If you drop by the COSEXA booth, exhibitor booth at the back of this room, they've printed the 3 clinical guidelines. Now, is your program COSEXA part of the COSEXA training? Surgery, orthopedics? Are you part of the?
Yeah, we have both at the hospital, but I come from the University of Nairobi. Yeah, the medical school of the university. Yes.
Because it's a standard of care that's been approved by COSEXA. So there's no reason why you can't bring this to the surgeons. And I know surgeons are very difficult animals. I'm one of them. And especially older surgeons are very difficult animals to change their ways because they've done it that way for 50 years. And if I change, then something bad's going to happen.
Yes, one more. The last one, please.
Thank you very much. I think your comprehensive response to the first question answered what I had, because my concern was how to facilitate surgeons being very hard-hearted people to accept the recommendations. But I think you have explained it very well. The second one was on the issue of the incentives. You said it's not monetary, but I think I would still like to have from you the kind of incentives that are influencing a positive change. We can also use the same kind of approach probably to assist in other health initiatives that where we want practitioners to adopt some new changes. Thank you.
So incentivizing surgeons to adopt the clinical guidelines. What do surgeons like to do? Talk to patients in consultation? No way. What do they like to do? They like to operate, right? And they like to operate a lot, okay? Now, if you can convince a surgeon or an orthopedic surgeon or an orthopedic department to adhere to some of these guidelines, he's going to be happy because the length of stay is going to decrease. Rather than having a patient in traction for 6 to 8 weeks, like many of the femoral shaft fractures are still treated in sub-Saharan Africa, patient's going to be out in 3 days. 3 days. Going to be happy, okay? The nurses on the ward are going to be extremely happy because they don't have to care for traction patients. They're extremely difficult to care for. They all become alcoholics in one way or the other because it's the only thing they can do is drink and play video games on their phones. So you incentivize them by offering them, giving them a little bit of extra OR time, operating room time. That's the way I'm going with this thing. I still need to convince the hospital administrators, still need to convince the team, but if you can convince them to adhere to the guidelines, you'll see that you'll have ripple effects on the entire team, not just the surgical team, but also the care team on the floor, and also the management team who has to pay the bills and argue for budgets. That's the way I'm going with this right now. You can also offer them, and this is where I'm going, about attending continuous professional development courses. We sponsor doctors to attend some of our courses, some of other competitors' courses even, to develop their skills. You know, the only thing you got to develop is yourself, your brain, and your hands. So this is where I'm going with the incentives right now.
Thank you so much, Dr. Martin, for your presentation. I hope we got something valuable. It wasn't in your plan. I think people were like, where does this come from? But I think you got it right. All right? A round of applause for Dr. Martin again. Thank you so much. Now, let us try to go for lunch and be here by 2:15. Yeah, just some 15 minutes before the usual time. I would appreciate that so that we don't extend time, because we'll have to come back here and have a bit of a presentation that we're supposed to be at this time before we go for parallel sessions. Thank you so much and enjoy your lunch.